WhatsApp, we'll be happy to answer your questions. Then I will take you the important questions that are asked regarding the long case. Then I will take you through the operative surgery and if time permits, a few benign breast disease. So starting with the clinical examination of the breast, these are the important topics that I intend to cover: history, clinical examination, diagnosis, differential diagnosis, investigation, and treatment guideline. Now, number one, this is about, say, a hypothetical case of a 46 years female who is a homemaker coming from Bardhaman district, presenting with the lump in the breast for the next 3 months. So the important histories that you need to actually elaborate is that the patient was doing well for till 3 months back. While taking bath, noticed a small lump in the right breast. It was 3 by 3. Now, remember here, most of the examiners now do not want peanuts, apples, and oranges. They're happy more with the centimeters. So based on the examiner's choice, you should be stating in centimeters, particularly for those who are appearing for the Indian exams. For the exams outside, for say around MRCS, if they are candidates, they still love the apples and oranges, and it's your choice to put in the centimeters of the apples and orange approximation. It was painless and localized to the upper part of the right breast. Over the last 3 months, it has progressed in size to attain in size. There is no history of nipple discharge. History of present illness. Here you must exclude the possible predisposing factor, that is history of pain, fever, or any trauma. Mark the word that we need to exclude breast biopsy, because it has been stated at present that multiple breast biopsies are a predisposing factor for progression of breast cancer. So you must ask the patient whether they have undergone a previous breast biopsy or not. Now, coming to the history of mixed metastasis, now you must ask whether there is any other lesion in the opposite breast. You can have a one-liner here at postgraduate level stating that the patient does not give any history suggestive of metastasis. You can have some fractionated it as pain, jaundice, headache, respiratory distress, or neurodeficit, but you can also state in a single line there is no history suggestive of systemic metastasis. In the history of past illness, the patient has not suffered from any major illness, etc., and does not have any breast-related disorder in the past. Now, when you come to the personal history, just take a screenshot of this, because you will be asked these questions. The age at menarche, menopause, parity, abortion, lactation, age at pregnancy, OCP intake, HRT, and non-hormonal risk factors like smoking, alcohol, obesity, previous exposure, and sedentary lives, and you all know. But the examiner is going to be very meticulous in asking each of them. And everything. The confusion points are lactation, number one. Now, there are few books which states that lactation has got no relationship, or the relationship is very weak. Now, for you to make it very clear and clarified, the answer is that triple negative breast cancer does not have any correlation. Rather, patients with hyperlactation also develop breast cancer in younger age grade, but the elderlies usually have a non-lactation as a link. The second question that is asked is regarding oral contraceptive pills. The answer to the question is the present day pills do not predispose to the possession of breast cancer. Now, mark my word, I am stating that the present day pill do not predispose. That does not mean the pills which were present 2 decades back does not predispose. They were estrogen-containing pill and used to predispose to development of breast cancer. Now, if you see a lady who is, say, around 65 years of age and has taken oral contraceptive pills for 5 to 7 years, that means she was taking a pill which was rich in estrogen, and therefore that would predispose to the possession of breast cancer. So you need to tell the present day pill, but if the patient's age group is such that the oral contraceptive pills was taken in the late 90s and early 2000 Y2K, then that would be a predisposing factor for the possession of breast cancer. Now, while you are asked to narrate about family history, what I ask all of you to understand that it is not a choice of only breast or ovarian cancer. It is also breast, ovary, prostate, colorectal, and or any other malignancy. So mark the words any other malignancy, because now there are 13 different associations which have come out, and each of them, even thyroid cancer, soft tissue sarcomas, desmoid, they all can have a correlation with breast cancer. So any particular malignancy in the family which has got one or more would predispose the lady to the possession of breast cancer. Now look here also what I intend to tell, 2 generations vertically. That means if you are dealing with an index case X, then you are looking at generation before and a generation, so mother and grandmother, father and grandfather, and 2 degrees laterally. That means you are dealing with her own blood related, own sisters and also first degree cousins. So all were included, and it is a good habit to draw a family tree, particularly in breast cancer, because between you and me, most examiners know a lot about what I said is breast cancer and the genetics of breast cancer. In treatment history, you should try to mention in history chart about what treatment the patient has undergone. So it's like many of the times during the exams for the national board or for the MS for the MRCS, I have seen candidates beating around the bush. If you see a lady whose hairs have fallen off, you understand that this lady has undergone a neoadjuvant chemotherapy. So you have to ask the patient, have you taken a neoadjuvant chemotherapy? If the patient shows you a paper where it is written that she has been taking CAF 4 cycles, you have to write that the patient has received 4 cycles of CAF, and that was after the patient has undergone a core biopsy, which had shown it to be a malignant lesion, which was ER/PR positive and HER2 negative, and the patient was put on this, and after 4 cycles, the lesion has gone down. So everything needs to be mentioned clearly at postgraduate level. It is your fault if the patient was presenting you with all the treatment papers and you have not noted it down. So coming to the clinical examination of the breast, number 1, try to understand there are 5 positions on inspection, and there are 10 zones. The 10 zones are, mark this, again a screenshot of this one is very important. Upper inner quadrant, lower inner quadrant, lower outer quadrant, upper outer quadrant, nipple areolar complex. These are the 5 which you all know. But you try to understand there is the 6th one, which is the axillary extension of the breast. The 7th one, the axilla, which needs to be inspected. The 8th one, the supraclavicular region, which needs to be inspected. 9th one, the ipsilateral arm, which needs to be inspected. And number 10, the opposite breast that needs to be inspected. So these are the 10 different zones which you need to inspect, and the 5 positions you are going to deal with during inspection starts with number 1, patient sitting straight, arms by the side of the patient, and it is in this position you mention about the size, location, etc., etc. Then comes arms by the side, and this is what you know that this is the position where the extent of the breast, the level of the nipple areolar complex, the quadrant point inspection, the size, etc. If the patient has further rounds, ulceration, satellite nodules, everything needs to be described. So this is the classical position for description. After that, the arms elevated. The purpose of doing this is to make an occult involvement manifest. That means the lady has got a small nipple tucked in lesion, and once the patient elevates, the whole nipple goes inside. So you make it manifest. So this is the position where you do this. And number 2, this is also the position where you can actually see the inframammary crease. So the purpose of doing the arms elevated is number 1, to see or to make an occult involvement manifest, and number 2, to see the inframammary crease. Then ask the arms on the waist. Now once the patient put the arms on the waist and tightens it, the breast becomes prominent. Now, the purpose of making this breast prominent at this position is, number one, if you find that there is a lesion which is fixed to the pectoralis major and the patient fixes the pectoralis major, so what happens is that immediately that becomes taut, and if the patient relaxes, it goes back. So that is a sign that is demonstrated on arms on the waist. So this is the third position. The fourth position is stooping forward. The patient stoops forward, and the affected breast and the normal breast are being compared. If you find that the breast is abnormally putting forward, that means it's a big lump which is putting the breast forward. On the contrary, if the lump is fixed to the chest wall, that breast may hold back, and therefore that is also a sign to tell that there is a possible fixity to the underlying structure with the lump. Now, semi-recumbent, this is a position which is not commonly used in Indian exams, but in the Western exams, Western format of the exam, this is the standard position. The patient rises in semi-recumbent couch and the arm is elevated above the head. So it is in this position that you see all the 10 zones at the same go. So in the MRCS or MLE exams, this is a standard practice. For Indian exams, the other 4 positions are the commonly used. Now coming to palpation, you know how it is being done, starting with temperature tenderness. And again, the 10 zones that I have told in the inspection has to be once again done through in the palpation. Now what you need to understand, these are the quadrants of the breast. Now, this is the palm of the hand, and this is the area by which you are going to palpate. So I have seen candidates pinching up the fingers to palpate a lump, which is atrocious at postgraduate level. It should be from the small square in the front of the fingers by which it should be palpated. Now, this is the palpation technique. Now, try to understand how it is done. Now, this is again a mistake that is being done by candidates who put in a tape around the surface of the breast. So that is an overestimation of the size. Instead, if you put in a caliper or get a projected diameter, that is the actual size of the breast that we are looking at. So don't make the mistake, as I said, of putting the tape along the curvature and trying to measure it. Rather, it should be done in the projected diameter or with the caliper to exactly measure the size of the lump. So once again, I have reconfirmed what has to be done. Now, if the patient has got any of these fissures, that is satellite nodules as you see here, or you find that there is extensive ulceration, or you find polyronge, these are clear-cut signs of involvement. I mean, you don't need to pinch up the skin to tell that that it is involved. It is involved. It is written on the face of the patient that it is involved. Now, what do you understand by an inflammatory carcinoma? This is a very important definition that is asked. It is an ill-defined lump. So the extent of the lump is ill-defined. There are features of inflammation over the skin, and there is polyronge which involves more than 1/3 of the surface area of the breast. So if it fits into these 3 criteria, then you tell that this is an inflammatory carcinoma of the breast. Again, we come to this differential. Now look at this. This is a patient who has got a nipple which is excoriated. This is a classical Paget's disease. On the right, you see a patient in whom the nipple is not excoriated, but the areola is excoriated. So that is a classical example of an eczema. So in case of eczema, we are going to get more of involvement of the areola and no involvement of the nipple, whereas it's just the reverse in case of Paget's disease of the breast. Of course, this is the technique which you all know, and this is again how to test the lump. You have to fix up the lump, hold it and try to move it from side to side the way it is being done. You all know, and this is how you try to move in both directions, and then you know whether it is fixed to the breast tissue or not. And this is how you fix up with the serratus anterior muscle. Again, all of you know, I'm not going into the details of this. The next question comes is, how does, I would just go back once again. This is the picture of the pectoralis major and try to understand whether the pectoralis major involvement is there or not. Now, in this case, first, the patient put his arms on the waist and you try to move the lump. You cannot move the lump. That means it's fixed to the chest wall. Then you are able to move it. Now you fix the pectoralis major. Now you are unable to move it. That means it's fixed to the pectoralis major. So again, this is undergraduate level, but again, I have seen candidates confusing things even in the postgraduate examination. Now, the difference between the impact of involvement of the pectoralis major and the serratus anterior, the pectoralis major involvement does not alter the stage of the cancer, whereas the serratus anterior straightway is a chest wall involvement and indicates a T4 lesion. So, axilla. And this is how it is done. You open up the axilla, put your fingers as high up as possible. As you go to the top, you'll be able to palpate the apical group of lymph nodes. And then you elevate it and put it down. Now you palpate against the medial wall of the chest wall and lateral wall. You push the whole thing and you try to palpate the central group of lymph nodes. And now you graze your finger down to get the central and the medial group of lymph nodes. And then you gradually, as you will see, you put your fingers up in front, and as you do that, the anterior group of lymph nodes come, and it is followed by the lateral group of lymph nodes. It's just brushing up. I am sure all of you know about this, and this is the posterior group of nodes that are being seen, and then you are going to examine the system to exclude the possibility of metastasis. And then you are going to give a diagnosis. The diagnosis, you must mention, this is a carcinoma breast of right side. It's a T4B N1M0 lesion. This is something which all of you are going to mention. But keep in mind, number one, the stage. Whether it is stage 4A, 4B, or 3A, 3B, 2A, TB, whatever it is, the stage grouping has to be kept in your mind. You must be able to categorize whether it's an early breast cancer, it's a locally advanced breast cancer, or it's a systemically advanced breast cancer. Remember also the age and the menopausal status of the patient. So you must mention this and keep this in mind. Now coming to the differential diagnosis. Now, as you go to the differential diagnosis is divided into two groups. One is the lump, the other is the ulcer. Now, if you look in terms of lump, these are the group of differentials which you must remember. Number one, breast cyst, phylloids, fibroadenoma, adenosis, chronic breast abscess, tuberculosis, IgM, traumatic fat necrosis. Ulcer, chronic breast abscess, tuberculosis, IgM, Paget's disease, and eczema. Now, if the patient is presenting with ulceration, then your differential will change. If the patient is presenting with lump, your differential is going to change. Of the lump, if the age of the patient is less, then it's a different differential. Of the lump, if the age of the patient is more postmenopausal, the differential is going to change. Because breast cyst is a classical feature of perimenopausal age group. So in a young age group, in the mid-30s, breast cyst is going to go down. And a fibroadenoma and a fibroadenosis is going to go up. So depending on the age and your presentation, again a screenshot of this is going to help you out during the exam. You should be able to prioritize your differential diagnosis. Now coming to investigations. Now in investigations, the triple assessment that is being done. is mandatory, which I am sure most of you would be answering, and the question of FNSC doesn't arise at whatsoever. The question is staging to what extent, and then investigation for general fitness for surgery. Now, before we go to this, try to understand that I will take you to another presentation where I am going to give you the details of what you should be answering. But for staging, you need to understand for early breast cancer, your staging should be restricted to liver function test only. Whereas in a patient with locally advanced breast cancer, you should be doing a CT scan abdomen, pelvis, CT thorax, and a bone scan. You should not primarily utter PET CT scan unless you are not provoked to, because NCCN puts it as not a mandatory one, but you can choose to do that. But the standard of care in most of guidelines are CT thorax, CT abdomen and pelvis, and bone scan. And then investigations for general fitness. Now look at this. This is the flow chart, again a screenshot which I want you to remember. Now, if it's an early breast cancer, there are different ways. We are going to deal with that as well. But this is the baseline. For you, you need to remember that if it's an early breast cancer, a node-negative patient, then it can be low risk, intermediate risk, or high risk. A low risk node-negative early breast cancer is one where the age is more than 35 years. The size is less than 1 centimeter. It is a grade 1 tumor. It's an ER positive tumor in such cases. So practically it's a 7 millimeter lesion somebody has detected in a 56-year study. And in that, no adjuvant therapy may be good enough. But anything above that, anti-estrogenic therapy is given. But if it goes to more than 2 such criteria, then chemotherapy becomes mandatory. Now coming to treatment recommendations in node positive early breast cancer, it is very clear the patient, once it is node positive, you go for surgery followed by chemotherapy. If it is ER positive, hormone therapy. If it is ER negative, no hormonal therapy is being given. And surgery should be compounded with radiotherapy, depending on the size of, the number of lymph nodes which are positive and whether the patient has undergone a breast conservation or not. Coming to treatment recommendations in locally advanced breast cancer, or which is called locally inoperable breast cancer. Number one, neoadjuvant therapy to downstage it. And following the downsizing of the lesion, we choose to have a simple mastectomy with axillary clearance or a breast conservation therapy, whatever the patient chooses to. Now, remember, if you are planning a breast conservation therapy while you have started the neoadjuvant therapy, a marker has to be placed in the center of the lesion. And then you follow it up with hormone therapy, chemotherapy plus minus hormone therapy, depending on whether the patient is ER positive or not. So we will complete the presentation here. So this comes as the first part of the presentation. We will move to the next class. Now, as I said, we are briskly running through this once again. What is your diagnosis? The questions that are asked, what is your diagnosis? What are the points in favor of your diagnosis? What are the possible differential diagnoses? How are you going to investigate? And what is your treatment plan? These are the 4 questions that are asked in all long cases. So you must be prepared to answer all these 4 questions. In breast, already you know that this is how you are going to deal with. So the differentials I have already told, the investigations I have already told, the diagnosis. Now, here as I was suggesting that you need to learn by heart about this. What are the mammographic appearance? The mammographic appearance depends on the architectural distortion. Now look here, this is an absolutely round lesion which is called a BIRADS 1 lesion. As it goes, as the margin becomes slightly obscured, it becomes BIRAD 2 lesion, then it becomes BIRAD 3, 4 and 5, depending on whether it's an absolute round lesion or it's a starry lesion that you see. Now, this is a classical example of a starry lesion that you see here, which shows it to be a carcinoma of the breast. Now, look here. There are small little dots which you find here. These are examples of a microcalcification. Now, I have put the once again here. Now, when you utter about microcalcification, always mention that it is called a clustered microcalcification. A clustered microcalcification means in a 1 square centimeter area, if you find there are pleomorphic dots, which are more than 5 in number. So in a 1 square centimeter, if there are more than 5 pleomorphic dots, that is what is known as a clustered microcalcification. So mere presence of 1 dot is not a significant microcalcification. It has to be a clustered microcalcification. Of course, you know about ultrasound, and this is the classical picture that you must be able to tell. Now look here, it's a lesion whose anterior-posterior diameter is longer than the transverse diameter. You find there is hello.
Sir, got disconnected.
Okay, am I connected now?
Yes, sir.
I was there. Are you able to see?
Yes, yes, sir.
Yeah?
Yes, sir. Now the audio is connected.
Okay.
Hello?
So as I said, if it is an anteroposterior diameter is more than the transverse diameter, if there is lack of perilesional halo, if there is acoustic shadows going like this, if the margin is irregular and it is hypoechoic, all these are features of a malignant lesion in ultrasound. This is again a malignant lesion in ultrasound. And this is the basic grading that you must remember: R1, R2, R3, R4, R5. You can have subdivisions of that, but that is not what you should be remembering. It's just that R1, R2, R3, R4, and R5. Now, MRI of the breast, you should not be uttering MRI routinely. Just remember that in lesions where you have doubt, you can choose to have an MRI, or else it is not normally used. Now, again, a question that is asked, particularly in locally advanced breast cancer, why do you need a mammogram? Because most of the examiners, when they see a big lump, they tell, say, look at this is a clear-cut lesion. You can able to tell, looking at the lesion, that this is a malignant lesion. So why do you need a mammogram? The answer to the question is, apart from the diagnostic purposes that we use, we can also assess the multifocality and the multicentricity of the lesion, the size of the lesion at the beginning, and the opposite breast. So these are the reasons why I chose to tell mammogram in the exam. Though, of course, looking clinically at the lesion, it appears to be absolutely a malignant lesion. You know this, why cytology has gone into oblivion. It is because of the less diagnostic accuracy. Less diagnostic accuracy, you cannot get IHC, and number 3, you cannot differentiate between, as I said, a DCIS and an IDC. And so therefore, needle core biopsy has become the standard of care. So this is a cytology and this is a core biopsy. So naturally, this is far better than the one that you see here. Now, systemic staging, as I said in the last presentation, that this is the standard of care. You can choose to tell PET-CT, but that answer should come later on. For God's sake, do not utter right at the beginning PET-CT. Most of the guidelines, including NCCN, is not openly recommending PET-CT as the standard of care. Now, treatment guidelines, as I said, we have already discussed this. Now, we are going to discuss something about the prognostication and prediction of the disease. Now, this most of you must know. These are the 5 different ways by which prognostication is done now. Number 1 is the age-old thing, that is the tumor size, the nodal status. Again, you know, less than 2 centimeter, 2 to 5, more than 5 centimeter, or skin involvement. Node, you say, is less, no nodes, 1 to 3 nodes, more 3 to 9 nodes, or more than 9 nodes. Grade 1, grade 2, grade 3. ERPR, Hernia, and Ki-67. This is the standard thing that all of you remember. Remember to tell about NPI, which is called Nottingham Prognostic Index. Just remember, you can search it, and there is a complex mathematics involved, how to calculate, and based on which you will be able to tell about the prognostic or the character of the cancer. You have to tell about this software, which is called an adjuvant online. And recently there is another software which is called EndoPredict. So I have not written the name, remember it, called EndoPredict. Then you must be able to tell about the molecular subtypes, luminal A, B, HER2, and TNPC and basal-like. And now you have got a large group of tests where you do testing for the proliferative markers based on the Oncotype DX and the MammaPrint. And again, you take a screenshot of this one to understand that these are the standard prognostic techniques. The only thing missing here is the EndoPredict, but these are the prognostic and predictive markers that are available today for planning the treatment and telling the patient what is the likely outcome. I'm not going to go. This is the new or the old slide, but in a new way. Now look carefully. This is the standard thing that we have been doing. Now you can choose to have a risk group approach in non-negative cancers by using the molecular markers instead of using these standard techniques. So that has also become a very viable option. But you must remember about all the 5 different techniques that are being used apart from the phenotypical markers and based on which we treat a patient. And this is about the locally advanced breast cancer. Now a bit of adjuvant therapy. Now indications of endocrine therapy are ERPR positive disease, and you know it's a premenopausal, tamoxifen, postmenopausal aromatase inhibitor. Now these are recent advances which I want part of you to remember. Number 1, aromatase inhibitor plus fulvestrant. The issue is not yet resolved. So as of now, we choose to have aromatase inhibitors alone, but with time, we might move to a combination, but as of now, it is aromatase inhibitor alone, but there are trials to show. This is the SWOG trial, which would suggest a combination is possibly better. Now, after you have done, and the patient has developed the metastasis, and the patient has progressed to the disease, and first-line endocrine therapy is not working, this is possibly due to the mTOR-AKT pathway resistance. And if there is a resistance, we can use a drug which is called everolimus. So if you use this everolimus, and this is again the trial which shows a combination of examastin and everolimus. Examastin is a postmenopausal anti-hormonal therapy. So examastin plus everolimus is superior to examastin alone, and that is because of the Bolero-2 trial. So if the aromatase inhibitor, that is anastrozole or letrozole, is not functioning, and you find an mTOR pathway a mutation have taken place, then you can choose to have a combination of these two. After that, it might once again progress. So then comes the next line of drug, and this is called palbociclib. And this drug, again you look at this, a combination of letrozole with a palbociclib, which is called the Paloma-1 trial. There's a 10-month survival advantage. So we have moved on from tamoxifen in premenopausal and postmenopausal to aromatase inhibitors, and from aromatase inhibitors we have gone to combination with fulvestrant, we have gone to combination of examastin with that of, as I said, everolimus, and now you have a combination of palbociclib with letrozole. And these are all recent advances which may be asked during the exam. And this is the cyclin D mechanism that works. So if it fails, then you can have an induction chemotherapy and then go to this. Now coming to HER2 positive disease. Again, the baseline that you know of is trastuzumab. That is the simplest option. Now we have a combination as option 2 of trastuzumab and pertuzumab, docetaxel levodopa. Now look here, if you combine both trastuzumab and pertuzumab, there is a 16 months average survival advantage, and this is after a trial which is known as the Cleopatra trial. So it will show that there is an advantage. So in today's era, you must be able to combine trastuzumab and pertuzumab. But pertuzumab is not a second-line drug. It is a combination drug to be used along with pertuzumab right at the beginning. And how it works, we all know that trastuzumab works to HER2/neu, and this one, that is pertuzumab, works to H3, EGFR3 receptor, and a combination of both are going to block the RAS/MAP kinase pathway, and once again give the patient a 16 months average survival improvement. Now, if again there is some sort of resistance which develops in the EGFR expression, and this is how it can develop, then we can move to the next line. And this line is called lapatinib and a combination of capecitabine. Now, capecitabine is a prodrug, which is a 5-FU product, but lapatinib is the drug which you must remember. And how it works, we have looked in H2 and H3 blocker. Lapatinib, this drug, works through H1 receptor. So if you can block the H2, H3, and the H1, again, you might have a survival improvement. The last drug that is found, which is costly, this is called TDM1 or trastuzumab emtansine. Now what it's done is, what it does, it is superior to a combination of lapatinib and capecitabine. What is done is that this is a targeted therapy. That means you have trastuzumab as the molecular target and you add or tag chemotherapy to it. So TDM1 is a novel innovation which probably has got the best possible result in metastatic breast cancer setting. Coming to the indications of radiotherapy, again, just one, if it is a locally advanced breast cancer or the margins are close positive, then you have to use it. For axilla, inadequate axillary surgery or gross extranodal disease or more than 4 nodes metastatic, those are the indications for axillary radiotherapy. Now coming to breast conservation surgery and the radiotherapy that we give. I'm not going to go to this here. I am going to stop the treatment part here. I will brush and move very fast to the next sector. And this sector, we will deal with the operative surgery of breast. Now going to the third part. I hope you are able to catch up. Anybody from your side? Or do you need a 5 minutes gap? Then I can give us a gap of 5 minutes and start once again.
So 5-minute gap.
Okay. 5 minutes gap. Okay. Then I will go to operative surgery. I will go put some water and come back and sit and take you through the operative surgery and the short cases. Okay? Okay. 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 everyone. Hi.
We are here, sir. We are here.
Yes, sir. Can we start?
Yes, sir. Yeah, sure, sir. Sure, sir.
You know, it reminds me of our course that we used to have while we were appearing for the FRCS exam. It used to start at 8 o'clock in the morning, and the guy who used to take those classes used to take that running in this speed, so that in 12 hours they will complete the whole course. So I understand it's very tough, but that's
But it's very productive, sir.
yeah.
It's very productive, sir.
Or else you won't be able to complete the whole thing. I need to take you through the whole journey of the important topics in breast. Okay?
Yes, sir. Of course. That's good, sir.
Yeah, fresh, sir. No problem. Okay, let's start. 1 second. Back to square one. Here. Okay, guys, let's go.
Yes.
Now, we are going to go into the operative surgery of breast. Now, look at this, and I'm going to take you through the 4 different techniques, that is modified radical mastectomy, the breast conservation surgery, the salient principles, the overview of onchoplasty, and finally through sentinel liquid biopsy. These are 4 important things that are asked. Now, how things change from mastectomy to conservation. Now, the earliest mastectomy, again, it is asked by some stupid examiners what is radical mastectomy. Now, radical mastectomy would mean taking out the breast in overlying skin, epidural complex, the pectoralis major muscle, the pectoralis minor muscle, remove everything. The newer textbook do not write, but you have to preserve the axillary vein, the cephalic vein, and the long thoracic nerve. So these are the 3 structures which are to be preserved. We call it a radical mastectomy. Then we moved on in those era to different types of mastectomies, called extended radical mastectomies to supraradical mastectomies. And the purpose was to give a bigger, larger clearance as there was no chemotherapy. But the cure remains the same. And for 100 years almost, that was the standard of care. And then people shifted to the procedure which is called practice modification of modified radical mastectomy. Here, everything remains the same, but the pectoralis major muscle was preserved. And if the pectoralis major muscle is preserved, the chest wall contour is preserved. And that is the advantage of doing a practice modification. Of course, it did not come by somebody's choice. It went to different, these are the major trials which prove that there was the overall survival. As you see, the DFS and the overall survival remain the same, whether you do a radical mastectomy or you do a modified radical mastectomy. So steps of modified radical mastectomy. Patient lies supine on the OT table, general anesthesia with endotracheal intubation, antiseptic draping and dressing, and this is how the position of the arm and the draping has to be done. After that, an incision is made. The medial extent of the incision, as you see here, is 2 centimeters from the mid-sternal line. The lateral extent of the incision is either along the anterior axillary fold or at least it has to go up to the mid-axillary fold. It cannot go beyond that. So this incision and the skin pad is taken so that this one and this one snugly fits. If you keep too much of skin, that will lead to a redundant skin. If you keep too less, that would be a difficult closure. And then the flap is elevated. What is the thickness of the flap? It is seen that small vessels pass into the skin, the dermis and the epidermis. So you have to go in between the plane of the breast gland and the subcutaneous fat. That is what you are going to answer during the exam. Sir, I need to go between the breast fat and the subcutaneous fat. The breast fat is pale yellow, whereas the subcutaneous fat is deep yellow in color. But that's theoretical. With time, you will be able to understand which is the plane. For your exam purpose, you are going to tell that my plane is between the breast fat and the subcutaneous fat. So in an obese patient, the subcutaneous fat may be thicker compared to a thin patient. And the upper extent of the flap will go up to the clavicle. The lower extent of the flap should go up to the decussating fibers of the external oblique and the external oblique and the rectus abdominis muscle. Medially, of course, the three perforators are the ones, and laterally you go up to the lateral edge of the subscapularis or the latissimus dorsi. Now, after you have taken the breast out, you are entering into the axilla. The guideline is the clavipectoral fascia, which is present at the lateral edge of the pectoralis minor muscle. So you need to make an incision somewhere here. As you make an incision here, you are going to gain access into the axilla. So the guideline for entering the axilla is the clavipectoral fascia. That's your answer in the exam. And this is the landmark that you need to remember. But if this is the axillary vein, your dissection should not go above the lower edge of the axillary vein. You should not go above this. If you go above this, then you end up in taking out the lymphatics. As a result, the lymphedema chances increase. What is the extent above? Now look at this. There is a crescentic ligament, which is called the Halsted ligament. You cannot go above this. So the lateral edge of the Halsted ligament is the superior most extent, of the apical most extent for a level 3 dissection. Medially, you have the thoracodorsal pedicle. The subscapular is going like this. But you have to understand that this is the thoracodorsal pedicle which goes, and the thoracodorsal pedicle gives one branch which goes into the thoracodorsal muscle. The latissimus dorsi and subscapularis, the other one goes into the chest wall. And this is the chest wall. So the extent will be this. You should not go. This is called the angular vein. The inferior extent of dissection is up to the level of the angular vein. So this picture is very important in understanding the extent of level 1, 2, 3 axillary dissection. After you have done that, you are going to put in a drain. Where to place the drain? The drain has to be placed as close as possible, but not exactly on the scar mark or the suture line, but as close as possible, preferably within an inch or two of the linear suture line. Because of the fact that I have seen people placing drain lower down. So what happens if you're planning a radiation? So you have to include the drain side. So what happens? The radiation field increases hugely, and there is scattering of dose. So the dictum is you should be placing it within 2 to 4 inches of the incision line that you have made in that particular lady. Now there are modifications. One is called the Auchincloss modification, which you all know that you are not going to cut the pectoralis minor. Instead, we are going to retract the pectoralis minor and do the surgery. The second one is called the Scanlon modification, where we are going to cut the pectoralis minor, do the dissection and reattach it. Again, this is an obsolete procedure. There is a third procedure which is called the pectoralis major splitting procedure. Try to imagine that the minor remains intact. The major is above. Now you split the major, and if you split the major, you will be able to see the minor. So you go to the medial extent of the minor, take out the level 3 nodes, and the lateral extent of the minor, you get the level 1, and behind the minor, you get the level 2. So this is a technique many of the surgeons also use. So you need to understand that Auchincloss modification, Scanlon modification, and pectoralis major splitting modification are the 3 modifications of the Pattis procedure. Now I'm not going to go into the videos here. Now, what are the complications of mastectomy? The complications of mastectomy are defined as number 1, the early complications. Number 1, the most important complication is seroma. Now, how do you treat seromas? You have to reassure the patient that these are absolutely innocent serous collection, either due to lymphatic pouring or due to extensive amount of raw fat, and the treatment of seroma comprises of repeated aspirations only. Number 2, a bleeding can lead to hematoma. Number 3, if you are too thin on the flap, then it can go to flap necrosis. Number 4, this is called restriction of the shoulder movement. So one must ask the patient to go into movement of the shoulder early on in the postoperative recovery period. Another very nagging problem is the medial aspect of the upper arm loss of sensation, and this is due to cutting the intercostobrachial nerve. So these are the early complications which you must remember. The late complications include movement, shoulder joint movement restriction, number 2, lymphedema and its complication. And there can be angiosarcoma which can develop on extensive lymphedema. And believe me, I have seen at least 5 or 6 of them, and they can be very notorious to deal with. Coming to the next part. The winds of conservatism was flowing in the 1970s. And it was because Fisher has published at that point of time that breast cancer is a systemic disease. And whatever you do on the gland doesn't make any difference. It is a systemic disease to begin with. And therefore, if you believe that, Fisher and Berenosi started the quad or the third form of therapy, which is quadrantectomy, axillary clearance, and radiotherapy. Or TART means tumorectomy, axillary clearance, and radiotherapy. Now we have the C-TART trial going on, which is a chemotherapy and tumorectomy, axillary clearance, and radiotherapy. Now axillary clearance has taken over by sentinel different biopsy in most centers now. Again, it was based on trials, and there were trials, as you see, once again, comparing modified radical mastectomy, and lumpectomy, and there was no difference in the local recurrence and the survival of the patients. What is being done, the basic principle is, it is not a fibroadenoma excision, it is something more than that. So what we do is we would excise at least 1 centimeter of tissue all around. So once this tissue goes off, that is tumorectomy takes place, we are going to radiate the rest of the breast with a radiotherapy and put in boost into the cavity that we have here. So it is basically a combination. Breast conservation surgery is a conservative surgery, but when you tell breast conservation therapy, it is a combination of surgery which is conservative, but a radiotherapy which is radical. So what are the contraindications? Again, you know, and I'll just put it on here. Now, most of them has become a relative contraindication now, pregnancy. Now, multifocality is gradually going into oblivion. It is only multicentricity, repeated positive marginal excision, past history of chest wall irradiation, collagen vascular disease, abnormal tumor breast ratio, a very large breast, and these are relative contraindications like low socioeconomic status, where patient is a poor compliant candidate for follow-up, or a distance from the institute is so long that they cannot come for radiation every day. But in the exam, you may omit this. You can focus on rest 7 different, and you can take a screenshot of this as well. Now, this is the principle. You can lay down the incision and make a separate incision to take out the axillary nodes. Now, this is again a separate incision, and the incisions can be 1 like this, 2, you can go to the anterior edge, and there are people who make it look like an S to take out the lymph nodes. So all 3, but as I said, this one is the most popular definite incision through which axillary surgery is being done. But this is after you have given linear accelerator to the boost, and the result can be amazingly perfect in most of the ladies. And again, people try. So after some time, as you know, surgeons are very egoistic person. They will try to take away, and they are very selfish people. So they wanted to get away with radiation. But if they tried, it failed. And it was proven once again that radiation has to be part of a breast conservation surgery. Now, this is after telecobalt therapy and brachytherapy. I mean, the results are not so cosmetically good, but LINAC is the best, but you can choose to have these forms as well. Coming to the second part, which is called oncoplastic surgery. Now, it is defined as a surgical procedure in breast cancer that aims to re-establish the body symmetry and thus plays a significant role in women's physical, emotional, psychological recovery from breast cancer. Now, in the West, again, I have put it in a broad gamut. Oncoplasty does not really mean a complete breast reconstruction. Oncoplasty means after you have done a breast conservation, you are reforming the breast. But for the purpose of the exam, you can definitely divide it into a total glandular replacement. And that is when you do, after following a risk-reducing mastectomy or early breast cancer, you remove the whole breast and reconstruct it. In this part of the world, we need this also for salvage reconstruction of locally advanced breast cancer and reconstruction of partial defects. Now, type 1 oncoplasty, where the volume of resection is less than 20%, then you can mobilize the breastplate and cover it up. But if the resection is more than 20%, then the volume loss is more. Then you need a volume displacement, that is reshaping or removing the breast from one side to other, or volume replacement, where you replace it by a tram flap or something like that. Now, this is an example of an implant. And as you see, an implant has been placed here and it has been covered by latissimus dorsi microperitoneous flap. Only implant is rarely used. It is always a combination of implant and the latissimus dorsi microperitoneous flap. Now, this is another thing which you need to understand. When we started with latissimus dorsi microperitoneous flap, the reason it failed was because we were not getting adequate volume. Now, the recent concept, which is called autologous latissimus dorsi microperitoneous flap, which includes taking the fat above, the fat below, which is called the love handle flap, and fat which is in front of the latissimus dorsi. If you take the whole thing, then you get a large bulk of latissimus dorsi based on the thoracodorsal pedicle, which can volume-wise match the opposite breast. So, of course, latissimus dorsi is only meant for small breasts. And this is an example of a latissimus dorsi microperitoneous flap which is buried under the breast. This is another patient. This is another patient where we have not used the volume but only the scale padding to cover it up. As I said, this is for palliative reconstruction. This is tram flap. And again, as you take, there are two vessels. One is coming the superior epigastric and the inferior epigastric. If you take a pedicle flap, then it is the superior epigastric vessel based on which the flap is taken. And I will show you after some time what is a TF flap as well. Now, this is how a tram can match. So as you see, tram, of course, has got the advantage that most of the Indian ladies will have a flabby tummy, and so you can feel the volume match in a better way compared to latissimus dorsi microperitoneous flap. But if you want a better result, then you can take deep inferior epigastric perforated flap. You look carefully, you will understand here that the inferior epigastric vessels goes like this underneath and comes out through the muscles and supplies the underneath fat. So if you are able to identify these perforators and without cutting or without removing the rectus abdominis muscle, you can take the whole thing and do a microvascular anastomosis. The advantage is there is no donor side morbidity. Whereas if you do a flap like this, you will always end up with a chance of herniation somewhere here because you have taken the transverse abdominis muscle and you need to put in a flap here. I mean, you need to put in a mesh here. This is another technique which has come, and this is called the technique of reduction mastopexy, which can be used, and this is how it can be used in cases. Just to give an example, that you can mobilize, even if there's a very big tumor, you can mobilize and take the tumor and get an attainment very close to this. This is called a reduction mastopexy. The scar is hidden underneath. You just need to understand what is this, and this is chest wall tumor excision, which has been also done in the world today. I'm not going. Now coming to the fourth part, that is minimalism in accident. How things have changed in accident. People have started with blind radiotherapy with NACDP04 trial, it has gone into oblivion, and all of them has gone into oblivion. And sentinel lymph node dissection has become the standard of care for early negative accident. And this was based on the theory. Again, you must remember the new theory, which is called the spectrum theory. We have looked into the Holstedian theory of orderly spread from breast to axilla to system. Then we heard about the Fisher's theory, which is a systemic disease with a local manifestation. But this theory, which came in 2000, is the actual theory based on which today our treatment plan is set. And this theory tells that there is a spectrum in that when we are dealing with centimeter, less than 2 centimeter tumor, they are actually local disease. And then it spreads into the axilla. Halsted told that axilla is the site where there is a fight between cancer cell and the host immunity, and after the host immunity fails, the cancer cell goes into the system. As if it was a big barrage, and you need to cross the barrage, the border to go into the system. But the spectrum theory tells no, it is not a barrier. It is just a place of immune reaction. So if you are able to tell that somebody has passed through the door, then you know there's a possibility something going into the system. And sentinel lymph node biopsy was done. And of course, you know that there are various techniques. For you to answer, it is isosulfan blue or methylene blue can be used. And you can use radiocolloids or a combination of two. And today we use also ICG or indigo cyanide green or indigo. There are other techniques by which it can be done. Now the technique is, we used to move it in the peritumoral. Now you can place it in the areolar, and then you can use the gamma probe to locate it, or you can use the blue dye to locate it. And then the intraoperative, if you find that the sentinel node has to be defined as hot or blue or both hot and blue. Hot nodes are 1, as in when the in situ count is more than 3 times the background count. I mean, you put the probe into the axilla, there is nothing. And then you put the probe on the lymph node, you find there is 3 times increase. Or you put the probe in other parts of the axilla, there is nothing. And the place where you have put the probe, there is 3 times more radioactive emission. And then you understand this is the site where there is the sentinel node. You can reconfirm it by looking at the color, which is blue. So you have to remove the blue node, the hot node. And even after removing the blue and the hot, you find some other node which are palpable. According to the recent definition, you have to remove the palpable nodes also. So it is no longer hot and blue, but hot, blue, and palpable. So naturally, a sentinel lymph node biopsy does not mean taking out a single node. On an average, it is between 3 to 4 nodes that are sampled out. You can choose to have a frozen section done in the operating room, and if you find it is positive, you can go back into an axillary dissection. You can send the specimen of the node for a biopsy or even an immunohistochemist, and if you find that there is a metastasis, you can call back the patient and go in and do another axillary dissection. So these are examples of how you can do it. And this is an old technique where we are doing the peritumoral. Now we can shift to the periareolar area as well. I'm not going into the biopsy. So we complete the operative surgery here. I go to the last part. Short case. The Again, before we go into the short case, I want you to look at and remember in a photo-frame memory how you are going to treat a node-negative early breast cancer. Risk approach, as I said, I have already shown it to you, and this is how a node-positive early breast cancer, and this is how you can go for a treatment recommendation for locally advanced breast cancer. These are things we have discussed. Now we come to short cases in breast. Now, this is the case 1. So look at this. What is a diagnosis? Of course, it is no doubt that it is a gynecomastia. So the question is, what are your differentials? Number 1, look at this. This is another lesion in the breast. Now this is a carcinoma and this is a gynecomastia. So the question comes, how do you differentiate? The answer to the question is neck or central lesions are gynecomastia and eccentric lesions are carcinoma. So remember the term, you won't be able to explain it that way. If it is a central lesion, then it is a clear-cut gynecomastia. If it is a peripheral or an eccentric lesion, then it is malignancy. Now, the second differential is between these two. So what is the difference? This is called a pseudogynecomastia and this is called a true gynecomastia. What is the difference between the pseudogynecomastia and the true gynecomastia? Now look at this. Now, if you find that there is a large amount of fat deposited underneath the breast, that is an obese lady or obese young boy, you can have a large amount of fat deposition and the breast look bulky. And at that situation, looking at it, it might appear it is a gynecomastia. But if you try to palpate, you won't be able to palpate anything underneath the nuclear complex. And this is what you can palpate in a true gynecomastia. So presence of a breast part is the sine qua non of a true gynecomastia, and absence of breast part is a pseudogynecomastia. So your differentials can be with malignancy or with true and pseudogynecomastia. How do you do, again, triple assessment? And if you find there is a definite cause to it, you are going to search for the cause, obviously. And these are the causes. You know better than me. You have gone through the MCQs and you know it can be physiological, medications, diseases, organ specific. So you just remember it by heart and vomit it out during the exam. How will you treat? Number one.
Triple assessment will do FNSC or for gynecomastia.
It's all core biopsy. Okay. If the answer to the question is yes, I understand what you are asking. Now, if your radiologists tell clearly that this is a nodular gynecomastia and there is no evidence of a space occupying lesion, or in other words, it's a clear-cut classical BIRAD 2 lesion, then a dual assessment is good enough. But if he tells that there is an SOL or an eccentric lesion, then you must perform a core biopsy. Clear?
Thank you, sir.
So reassurance or surgery for cosmetic reasons. Now this is the grade. Again, try to remember. Grade 1 is there is a nodule. There is no skin stretching. There is no ptosis. Grade 2, nodule has increased. The skin of the neck has stretched, but there is no ptosis. Grade 3, the nodule have further increased. It has gone beyond the nuclear complex, and therefore the whole skin is stretched to a large extent, and you have ptosis. So, based on this, it can be grade 1, grade 2, or grade 3 gynecomastia. And of course, if it is a grade 1 gynecomastia, it's a pseudogynecomastia, you can just do a liposuction and make him clinically obviously fine. A grade 1 and grade 2, need subcutaneous mastectomy because many of the plastic surgeons do try with breast nodules. But if there is a solid breast part and breast tissue, even if you try, it does not give that much of characteristic cosmetic outcome. So in those cases, a combination of liposuction and subcutaneous mastectomy is good. But as surgeons, we prefer to do a subcutaneous mastectomy. But if it's a grade 3 lesion, then apart from subcutaneous mastectomy, we need to excise a part of the skin and lift the nuclear complex so that a mastopexy is also achieved. Coming to the second case. What is your case? Now, obviously, looking at this, you will understand this is a phylloid tumor. What are the differentials? Number 1, phylloids. Number 2, phylloids, which is varieties. And number 3, it's a CA breast. How will you investigate? I'm going to go for a good clinical breast examination, a radiology as per triple assessment criteria, and a core biopsy. Now, features in mammogram. Now, look at this. They are completely indistinguishable from a large benign or a giant fibroid adenoma. There is no microcalcification. So a mammogram cannot differentiate whether it's a giant fibroid adenoma or it is a phylloid tumor. Now look at this. This is the way you can differentiate in ultrasound. If you have a lesion which looks like this, which is a fibroid adenoma, it's a benign lesion, no doubt about that. But if you have clefts like this within the lesion with heterogeneity, this is a phylloid tumor. A fibroid adenoma will not have a cleft inside. So this is the hallmark by which in ultrasound we are going to differentiate whether it's a fibroid adenoma or it's a phylloid tumor. Look carefully, this is a bigger ultrasound image and you see those clefts that are there within the tumor to tell that it is a phylloid tumor. Now, I'll try to understand the surgical pathology. Now, this is a lesion. As it grows in size, it stretches the breast ductoglandular system. Doesn't involve them. This is a parenchymal lesion. As it grows in size, it further stretches everything. And then it continues to grow in size. As it grows in size, it will grow in size and it might derive, I don't know where the animation went, it starts deriving small little vasculature from the surface. What about the margin? Now, this is a classical fibroid adenoma. The phylloids look like this. Look like it has got leaf-like projections all around. In a fibroid adenoma, you can enucleate and shell it out. If this is a phylloid tumor, if you shell it out, it grows like this. You shell it out, what happens is this. The patient has multiple leaf projections, microscopic projections left behind, and the patient is going to come back with bad recurrences. So the difference in excision technique of a fibroid adenoma phylloids is in a fibroid adenoma, you can shell it out or enucleate it out. Whereas in case of phylloid tumor, it has to be a 3-dimensional 1 centimeter margin excision that is being done in case of phylloid tumor. If you do not do this, you end up in having these sort of ugly recurrences that you can have. You have to know about the grading of phylloid tumor, which includes the benign, borderline, and malignant, and it is then dependent on the stromal proliferation, the mitosis, the margin, and the archipia that you see. You may or may not remember, but you need to understand that there are benign, borderline, and malignant form, and it's dependent on the number of mitosis and the stromal proliferation. As I said, 1 to 2 centimeter. Simple mastectomy is not the answer, simply because nobody would like to have the breast removed for a benign lesion, and therefore you must try to do all sort of oncoplastic procedures. To summarize, FNAC has to be replaced by core biopsy, even in fibroid adenomas, because of the simple reason you can miss out a phylloid tumor. Stromal overgrowth is the most essential criterion. Wide local excision with or without oncoplastic is the procedure of choice. Mastectomy is not the standard of care. Axillary intervention is not indicated. weak evidence in favor of radiation. There are radiation oncologists who would like to give radiotherapy, but that's not the standard of care. Only metastatic phylloid tumor you can have some sort of chemotherapy for palliation, but there is no evidence in favor of survival advantage with chemotherapy. So thank you very much. So I end the whole thing here, and I thought I won't be able to complete, but I was able to complete and get you through the two important short cases, phylloids, fibroadenoma, and then, as I said, about gynecomastia and its differentials, the long case operative. I hope if you go through this, that is more than enough in terms of your viva, your theory, as well as your practical exams. I'd be happy to answer any question.
Sir?
Yeah.
Sir, where exactly the role of oncotype DX comes in?
That's an excellent question. As I said, we were talking about a group of patients who are, say, yes, this one also. Now look at this patient. It's a node-negative patient. So you can follow a policy of blindly giving chemotherapy to all of them. We used to do this. Instead of doing this, if you have this, you can have an oncotype DX done. The criteria to use oncotype DX is node negative, ER positive cancers. In them, if you try to eliminate chemotherapy, you do an oncotype DX. And if you find the score is less than 11, then you need not give the patient anything than hormone therapy. 11 to 18 is borderline, it's a gray zone. Above 18, chemotherapy becomes mandatory. In India, now we have something called an CAN-ASSI score. There, if the score is less than 15, it's a low risk group, no chemotherapy is required, only hormone therapy is good enough. If it is more than 15, a hormone therapy is chemotherapy is required. But if it's a node positive or a triple negative breast cancer, then the question of oncotype DX doesn't come because those are really aggressive cancers. Clear?
Thank you.
So thank you guys. What I would suggest is you just go through the whole thing, jot down the questions and send it to me through Shilajit or through Dr. Rudrajit Sinha. I'd be happy to answer all the questions. If you have any queries beyond this also, I also would be able to answer those questions. Okay?
Okay. Thank you, sir.
Thank you very much. Thank you very much indeed.
Sir, tomorrow's class will be at 8 p.m. now. Timing for tomorrow's class?
I won't be there in tomorrow's class. So I think Shilajit, at what time the class starts tomorrow?
Yes, sir.
Yeah?
8 a.m. Okay,
8
sir. Okay. Thank you so much, sir. Thank you so much, sir.
Hope this is helpful. Any feedback or anything else that you need to learn on this?
It has been very helpful, sir. We got a review of maximum of the things that could be asked. Now we can revise and focus on the topics more.
Okay, because we want the feedbacks from you so that we can improve as well. But we wanted to cover as much as topic as possible.
Yes, sir.
So thank you very much.
Thank you so much, sir.
Thank you, sir.
Okay. Thank you, sir.
Tomorrow, sir, will be from 8 a.m. morning. And the Zoom link will be sent at around 7:30 a.m. at morning in the group. Yeah. Thank you. Say good night.
Yeah.
Welcome to the boot camp. Today we are talking about hernia, and it is actually divided into, initially we'll talk about the inguinal hernia first, and then we'll talk about the ventral hernia. It's a fairly long presentation with many concepts. The basic thing is something which you're expected to know, and I will not delve on it, but rather focus on a few things which they ask in the examination, especially the viva examination, might be asked in the OSCEs as well, and some difficult concepts for you to grasp, which they might ask you if you answer really well in the examination. So if we start with inguinal hernia, you have to make the entire your viva very simple. Don't speak more than what is necessary. And the first chief complaint, especially the chief complaint of any hernia, most important is the swelling and the pain. Don't say things like, even if they say something like I have fever or something like this, fever is not connected to hernia at all. So just speak to swelling and the pain. Now, when you got the history of present illness, if the patient was apparently well 3 months ago, use the term apparently well. It's very, very important for you to use. 3 months ago, when he first noticed, he first noticed swelling, and in the swelling you have to identify the location, right and left, mode of onset, spontaneously after a bout of coughing, appeared first in, which is very important, where the first appearance is below going up or up going down. Progress of the swelling from groin to scrotum. Aggravating and relieving factor, which is most important in all hernias. Period of irreducibility, and always, this is very important, finish by saying any swelling on the opposite side. Right? Don't miss out these salient points when you're describing swelling in the history of presenting illness. Pain, of course, the site, radiation, the character, relation of the pain to straining and relieving factors. You see, both has, one is aggravating and relieving factors for swelling, and relation of pain to straining and relieving factors in pain. This is the most you should say, and this is the least you should say, especially in a case like inguinal hernia, which is actually not a honors case, but is definitely a failing case, if you know what I mean. In this level, if you cannot say everything about inguinal hernia, it will not be seen very good with the examinations, right? Next, we go to straining factor. In straining factor, which is very, very important. Again, there's three things in straining: chest, abdomen, and bladder. By chest, what we mean is a chronic cough, breathlessness, and history of bronchial asthma. In abdomen, which is constipation, and in bladder, which is dysuria, urgency, precipitancy, and hesitancy. And you should know the definition of each of these things. So go to a textbook or a good site of the net and find out about dysuria, urgency, precipitancy, and hesitancy. Narrowing of stream, nocturia, and history of acute retention of urine. See, this is very, very important. So all history of present illness in a hernia case should start with straining factors of chest, abdomen, and bladder. Do not miss out a single point over here. Then you move on to relevant history, other relevant history, like fast history, similar swelling in the same or the opposite side, history of any operation done, personal history of smoking and alcohol, so it's very, very important. Any family history is not that important because I don't know about any familial thing about hernias, especially except some collagen diseases. Treatment history is trust, with patient using trust or not, and any allergy history, which is very important regarding any medication that you might give in the operative and post-operative period. Now, physical examination. Of course, we start with general survey, local examination, and systemic examination. The reason we tell you about all these things is because we don't want you to make an MBBS level mistake here. So it is always a general survey. And in the general survey, we at CCC are very, very clear that your general survey has to be, has to be perfect, because a lot of postgraduate examination and even super specialty examinations, people fail because they cannot master the general survey, they cannot speak properly. So we call it a graveyard of specialist and super specialty examination, because if you are crossed in a general survey, that you can, it is not very good for you regarding the passing of the exam in the postgraduate and the super specialty exam. In MBBS, you can be given another chance. So over here, you can say I have taken consent and under proper lighting with my patient comfortably lying, sitting and standing with adequate exposure in the presence of an attendant proceeded with the physical examination of my patient. This is the first line you should start for any general survey. And then in one line or in one breath, if you know very well, you have to talk like this. My patient is conscious, alert and cooperative with an average build and normal gait and decubitous of choice. He has good nutrition and hydration. He shows no evidence of pallor, jaundice, clubbing, cyanosis, edema. Neck glands are not enlarged and neck veins are not enlarged. So this is paragraph number 1, which you should say in one breath. This is paragraph number 2, which you say one breath. Please practice in front of the mirror and you memorize this and deliver it, because it is very important when the examination looks for clues whether you are presented before, and if you haven't, you will hesitate over here. So if you haven't presented, just remember this, memorize it and deliver in front of a mirror and see how confident you look. Right? Then from here you can go on to the pulse, PP. Third is your pulse, PP, respiratory rate, and whether the patient is febrile or not. And then you move forward for your local examination. Local examination, again, I will not get into the details of it because it's a very long presentation and you must have practiced this right from the MBBS level. So the abdominal examination, groin, then do an inspection on standing, palpation on standing, palpation supine, percussion, auscultation, rest of the groin. You have to see rest of the abdomen, you have to see, including the opposite side. Don't forget to see behind also, the back. The digital rectal examination is very, very important, especially you have to mention about when the patient has, especially in males, any prostatomegaly or not. Know the grades of prostatomegaly with finger. So grades of prostatomegaly, please refer to a very good book. There are many grades, so you have to know, definitely they'll ask to define each grade. And of course, the chest to see any kind of noises are there or not. Then, of course, don't forget the systemic examination, especially the abdomen and the respiratory. All quadrants must move equally in the abdomen with respiration. No obvious fullness or lump or scar mark detected. No evidence of fever or bowel sounds. They appear normal. In the respiratory, both sides of the chest move equally, normal breath sounds and no adventitious sounds. It's very, very important. The examination of the CVS and CNS is, you have to say the last line like that. Right. Now, after you finish the examination, the diagnosis, which is again, the examiners look at you like for you to drop forget anything. But again, you memorize this. You have to say about right and left, whether it's the inferior or the femoral hernia, whether it's direct or indirect hernia, whether complete or incomplete hernia, whether it's reducible or irreducible hernia, whether the intestine or omentum has a content or not, or whether it is right now complicated or uncomplicated. The examination, which will be the patient which will be given to you in examination will be uncomplicated. But for complicated, it means that the patient is in his pain which is unrelieved by medication, any abdominal distension is there or not, or any fever is there or not. So whenever the patient can be asked in a different way later in the viva. So when do you know the patient has developed from moved from uncomplicated to complicated hernia? Is it when the patient has unrelieving pain, not responding to any analgesics, and there's any kind of abdominal distension that might signify a bowel obstruction, and whether there's any fever, whether the strangulation is present or not. So this is a very, very important slide because you have to say each of these 7 points minimum. Okay, so don't forget this. So the next question, as in all examination, especially in postgraduate, is that what will you do next? So first start off by saying, I will explain to the patient the need for an elective surgery. I will plan, and whether the patient would require surgery in uncomplicated one-side hernias, I'll come to later, because that comes under the guidelines. But in the examination at your level, always choose for an elective surgery. I will explain the patient the need for an elective surgery. Of course, if the patient is not obstructed if it's a uncomplicated hernia. I will plan for an open anterior or a lap approach. You can say either or. No one is better than the other. If in your hospital they are still doing open anterior, then do say an open anterior approach. Open approach. If you feel you're fairly confident in this time with the lap approach, either DEP or DAPP, go ahead with it. Before operation, I will tell the patient to stop smoking, reduce weight, and we then proceed to the pre-op fitness investigation for general anesthesia fitness. Right? Now, whether to do USG and all, again, this goes to the guidelines. I'll tell you later. Now they ask you why does the hernia occur? This is an offbeat question. So you say it's basically, sir, because of two things. There's increase in abdominal pressure and the weakness of the abdominal wall. Increase in abdominal pressure and a weakness in the abdominal wall. So what do you mean by increase in abdominal pressure? Which is the cuff. Now this cuff is always, don't stop as cuff. Always use the term in any hernia describing a cuff, saying it is a chronic cuff. Okay, don't forget this. Always when you say any cuff related things in hernia, say chronic cuff. Chronic cough, bladder obstruction, constipation, straining, ascites, intraabdominal malignancies, and pregnancy. Increase in abdominal pressure and a weakness in abdominal wall, which is congenital, which is patent vaginalis, patent kernel of Mach in females. Acquired is excess fat, post-pregnancy, surgical incision, connective tissue disorder like Marfan syndrome. Okay, so these are all important things to know. Now, why is this a hernia? Again, an offbeat question. So, in this 40-year-old male, okay, swelling which started in the left groin and subsequently increased in size and descended into the scrotum. So basically it started in the left groin and subsequently increased in size and descended into the scrotum, which is point number one of why is this a hernia. Swelling we call a hernia. Second is that, again, aggravating and relieving factors, increased in size on walking, straining and coughing, decreased on lying down. Point number two. And three, on examination, left side swelling is not possible to get above the swelling. Point number three. So any hernia, you cannot get above the swelling from examination. And there's an expansile cuff reflex over the swelling, which is point number four. Okay, so they might ask you which are the conditions in hernia where there's no expansile cuff swelling, you might be ready with that answer. Right? So there's 1, 2, 3, 4. You have to say all of these things. Okay. This 40-year-old male thing, I just said it. Don't say it as point number one. So when you are telling that in the exam, just say the specific of the exam. 40-year-old male having a swelling which started as so and so. A differential diagnosis of a swelling, of the inguinal swelling. Okay, it's this is a MBBS question, so you must be knowing the differentiation factor of each. Femoral hernia, congenital hydrocele, hydrocele of cord, lipoma of cord, epidermal cyst, and varicocele. I will again not go into this. What are the other swelling which causes expansile cuff impulse, which is important, like a meningocele, encephalocele, and laryngocele. Next, what will you do? I will plan for surgical management of this patient. I will do a blood test, urine test, chest X-ray, and ECG. For cough, chronic cough, again, chronic cough, I will do the pulmonary pump function test. And for the prostatism, if there is any sign which I see in my history, I'll do a USG KUBP. And the most important sign, you have to say that USG KUBP with residual urine measurement. This is very, 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 very important. Okay? When they ask you in KUBP what is more important, don't say the prostate size. Say that I will have to look at the residual urine measurement, okay, which has a particular figure. If it is more than 30 ml or 40 ml, I'm not too sure when. Just see when it becomes positive from your uro colleagues. The residual urine measurement is very, very important. That is something which you have to know. And if the patient still has some kind of a urinary obstruction, but the USG is okay, you have to go for a uroflowmetry, which might measure the urine stream, the urethra, whether the restriction present or not, because you have to address all these issues before you get into hernia treatment. This is the NIHAS classification. I'm not getting into this. This is something which is there in all books. You'll have to know this, unfortunately. You can do that. This Gilbert classification also you'll have to know. Just don't go more than this because you'll get confused. This is exactly what is required in the examination. Now, for the options is that if it's a non-mesh repair, which they don't do nowadays, all under repairs are done by mesh, especially in certain conditions. You can do a shoulder, Bassini or disorder. In open, we have a Liechtenstein, transinguinal preperitoneal, it's called a TIPP. But in the Liechtenstein, something which you have to know, plug and patch is also very, very important. PH is something which a lot of people do. So what I have done in the examination, that for non-mesh, I used to memorize one procedure. For open, I memorized Liechtenstein, and for endoscopic, which is TEP, which I was doing in postgraduate. In my institute, I used to do TEP, so I decided TEP. So, but there's not only TEP, there's transabdominal preperitoneal also repair. So those things are important. So, if you ask my opinion, just remember the shoulders, a Liechtenstein, and a TEP or TAP, whatever it is done. Okay, so don't go for more than this. This is not required. What operation? Open would be, you describe it as such, Liechtenstein tension-free mesh hernioplasty in this patient under regional anesthesia or general anesthesia, so we call it. Liechtenstein, okay, the spelling is important, you should know. I'm not sure this right spelling or not, but just check. Tension-free, important word. Mesh, important word. Hernioplasty, important word. And whenever anyone asks you an operation, please complete it with an anesthesia which you use. Okay? Unless you say the anesthesia, the operation name is not complete. This is not a rule, but this is actually a very good practice and gives a very good impression in the patient in the surgical examination, the examinee's mind. Okay? For laparoscopic, you can also set the transabdominal peritoneal under GA. Okay, or depth under G. Right? So don't forget to do that. Don't say things like spinal anesthesia and all these things. Just say G and just let the examiner ask you questions. Operations to know. Bassini is as only one herniotomy, shoulders, stroparipa, GPPRs, which you just know the 4-5 lines on all of these things. Local anesthesia is again you will find in the books, you can just see it, but it's important for you to know. I just put the slide in because it's sometimes asked in the examination. Now, complications, it can be start with the general and the local. In general complications, we have the pulmonary, cardiac, and the urinary retention, which is there postoperatively, and local, which is more important, especially in your hernia. It can be an hemorrhage, urinary or bladder injury, injury to testicular vessels, testicular swelling or atrophy, injury to vas deferens, due to nerves, wound infection, recurrence, and edema of penis. Okay, so you'll have to know especially hemorrhage, which is there, urinary or bladder injury, which is especially it can be there during TEP because you're operating in very small spaces, and injury to testicular vessels, testicular swelling, and testicular atrophy. Okay, can be a small vascular injury which can cause testicular atrophy over there. Injury to vas deferens, injury to nerves, wound infection, recurrence, and edema of penis. Okay, so just know about all of these things. Now they'll ask you a theoretical question. What do you mean by Hasselbalch triangle? All of you know from I think first year of MBBS about Hasselbalch triangle. So this is a triangle which is bounded and this is a mirror image. I've taken a picture from the net and I've done a mirror image of it, so that you know the right and left. Because the remaining part of the presentation, I'll have to tell you about the right and left, so don't get confused over there. So basically, you have the rectus abdominis over here, which forms the medial border. Wait, I'll change my color. This forms the medial border, right? The base is formed by the inguinal ligament, and then there is the inferior epigastric vessels. Now, the importance of Hasselbalch triangle is that it identifies one area, which is the direct area through which the direct hernia occurs. If it is towards the lateral side, this is the area of the indirect hernia, and then this is the femoral hernia. So you can see the 3 triangles over here. Okay, so this basically tells you the Hasselbalch triangle defines the direct space through which the direct hernia occurs. Now, what's the myopectoral orifice of Fusha, which is also very, very important, which is asked by the examiner. The medial is by the lateral border or rectus abdominis, which you can find over here. Okay, don't just say the border of the rectus abdominis, it's lateral rectus abdominis. Laterally is where the iliopsoas. Now, this is the another lateral border. Superior by the arched fiber, the transversus abdominis, this one, and the internal oblique, and inferior is the pecten pubis and the bony pelvis. So this area is called the myopectoral orifice of Forshaw, because as we have human beings have come from animals, so from the animals we walked on 4 limbs, but then as we become upright, this space has opened up over here, which is actually not covered by bone, neither if it is covered by a strong fascia. So it is basically a potential space through which most hernias of the groin occur. So how? So this again divided into by the inguinal ligament into upper and lower. From the upper segments we have the direct and the indirect hernias, and the lower we get the femoral, the upper segment and the lower. Okay, so again, this is very, very important for you to know, and this certainly will be asked. Know the big vary of the spelling of Frushu. Again, you can see right and left I have done. You can see again that the lateral border forms the, again, I think this I've taken from the net picture. See the lateral border, medial border is the lateral border of the rectus abdominis. Lateral border is the medial border of the iliopsoas. Superior is the arched fibers of the transversus abdominis and the internal oblique, and lower is the not the inguinal ligament, the pecten pubis over here. Okay, post ligament, the pecten pubis. The inguinal ligament actually divides the myopectoral orifice Forshaw into the above where the indirect and direct hernia occur, and below where the femoral femoral hernia occur. Now, this is a concept you should know about the inguinal ligament and the iliopubic tract. Some people are confused. I just put the slide over here. This is a very good picture that I got from a book. See, from an open surgeon view, okay, when we are looking from here, so we are looking from the top, okay. So what we see, we cross the external oblique first, then we can see the internal oblique, then we can see the inguinal canal, and then we can see the hernia that occurs from here, right? But from a lap surgical view, okay, what we see when we reach the correct plane, you see the transversus fascia, right? Transversus abdominis, we can see the internal thing like that, and we can see this condensation is called the iliopubic tract. Okay, so don't say you can see the inguinal ligament from the lap view. You can't. You can see the iliopubic tract with the reflection of the inguinal. So this is the inguinal Cooper's ligament. You can see this is the inguinal ligament, and this is the iliopubic tract. Okay, so don't get into that confusion. Now this is a sort of a walkthrough about a lap view, which you should know. It's very difficult for people who have not done laparoscopic TEPs or a TAP for them to understand this extremely difficult anatomical view. But once you get through this slide, you will have some idea. I've got this on the net, on the YouTube channel also, you can see. So the first thing you can see is I have drawn is just draw. You can take a blank piece of paper and just start drawing whatever I start drawing on the slide. Okay, I'll give you 10 seconds or 15 seconds to get this paper, right? Just blank piece of paper and just with a pen, and you just draw with me and you will understand, right? Right, if you're ready. So the first line, which is the inferior epigastric country, don't bother right and left, which will come later. Okay, then you draw another line, which are the gonadal vessels. This is the laparoscopic view that we're trying to appreciate, right? And then draw another line on this side called vas deferens. Now, this is the template. This is something which you'll have to see if you open any space to see about hernias. You have to identify these 3 things first. What do you see? You see an inferior epigastric artery, which you can identify as soon as you get inside the abdomen, especially in TAP. When you take out the peritoneum, you can see the gonadal vessel, the vas deferens on 2 sides. And similarly, now you do left, right, you can see both like this. You can see the inferior epigastric straight line, gonadal vessels, which line that goes, the limb of the thing which goes laterally on both sides, and the vas deferens are thing which comes towards medially. Okay, these are 3 structures we should know, right? Everyone has drawn this, right? Okay, so slowly I'll make it more complex. So unless you get this, and this is the central basis of everything, you will not be able to proceed further. So intraepigastric artery, gonadal vessels, and vas deferens. So the next thing is that you can see a cells, where the impression of inguinal ligament in that view is the iliopubic tract. You can see it going, almost going right from the midline on horizontally, right? Again, the fourth line which I've introduced. Okay. Again, once you start identifying these things, whenever you're saying a 10, you find the anatomy becomes very, very simple. So now we can identify the three spaces over here. The indirect space, which is the space lateral to the inferior epigastric artery. I'm not annotating here because in this there are a lot of other structures also. So the inferior epigastric artery is there, and the space which is lateral to it is the indirect space. The space which is between the inferior epigastric and the iliopubic tract, which is called the direct space, through the direct hernia occur. And the space between the iliopubic tract and the vas deferens is called the femoral space. The femoral space occurs. So left and right, you can see is a mirror image of each other. So it's very important to get that initial inferior epigastric and gonadal vessels and vas deferens right. Okay, remember the vas deferens goes medially, always goes laterally. Right. Now we space things which are important in between these spaces. So between the space between the vas deferens and the gonadal vessels, you find the external iliac vessels on both sides, right? Between the space between the gonadal vessels and the iliopubic tract, which traces laterally, you'll find a lot of fibrofatty tissue. You will not see these nerves, but these nerves will be containing within the fibrofatty tissue over there. Okay, so this is the area which you should not skeletonize or take the fascia away. Just let the fat be over there. It does not bother you, so don't touch it over there. Also, this is the area in which you should not put any tackers or any sutures, right? The space between the iliopubic tract and the gonadal vessels. Right? Okay. Now, especially when you are doing a tap, what we do is that this purple line that you see all around is a reflected peritoneum. So basically, I've taken off the peritoneum on all sides, and then we can see this. In a tap, you're already in the space, so there's no reflected peritoneum. You'll see this. Okay? Right. So we have identified two things, which is the same. We have identified the nerve that's in one particular place, and an important vessel like external iliac vessel in an important place is defined by triangles. Okay. Now these are not two triangles because you don't have three sides to it, but it is something which you have to understand. So triangle of doom is why people are doomed, because if you puncture an iliac vessel, it is like very, very bad, because you have to stop the vessel bleeding and then do a lot of other measures in which you open it and you can see it. So this is called the triangle of doom, where you should not use any blunt dissection, sharp dissection, neither should you use any cautery or energy sources over there. So this is bounded by, again, you can say it by seeing this picture, medially by the vas deferens, laterally at the gonadal vessel. The apex is the internal ring, that confluence point, and the base is formed by there's no structure over there. You can say the line joining the two or the reflected peritoneum. Okay, that is the triangle of doom, which contains the external iliac vessels. The triangle of pain is what? Laterally, medially will be the gonadal vessels, laterally will be the reflected peritoneum, and the base is formed by the iliopubic tract. Right? It's an inverted triangle. Okay, which contains the important nerves like the genitofemoral nerve, the femoral nerve, and the lateral femoral nerve of the thigh. So they'll ask you what nerves are there. You can say genitofemoral nerve, femoral nerve, lateral nerve of the thigh. So these triangles are important. There's the areas in which you should not do any sharp dissection, neither should you do any energy source, and neither should you put any kind of suture or tackers in this area. Okay, so these triangles are important. Okay, some people combine the both things and call it a trapezoid of disaster. But unless you're asked this, and very few people who know this, you ask, not important. Fine, right? Okay, where do you go next? So next we can see that there's the bladder is there, and which is joined by this urachus, which ultimately forms the median umbilical ligament, and then you can see that obliterated umbilical artery, which is formed by the medial umbilical ligament, and the partial condensation or peritoneal condensation across the inferior epigastric artery is called the lateral umbilical ligament. Okay, where does it go next? So we basically can put the symphysis pubis over here. Symphysis pubis comes something like this. Okay, you can see the lateral aspect, you can see the Cooper's ligament over there, and also you can see a connection forming from the triangle of Doom. This vascular connection from the triangle of Doom, from the epigastric, from the iliac vessels right up the ocular artery, right up to the inferior epigastric artery. Okay, this is something which goes behind the symphysis pubis. This something is known as the corona mortis. So you have to be very careful not to do any kind of dissection below the Cooper's at that particular area, because there is a lot of bleeding. The bleeding is not the problem. The problematic is that it's very difficult to control the bleeding because it is a very small thing that goes inside. You're not going to control it to make more disasters. So the better still is that don't do any dissection on that area. Okay, so you see the communication, direct communication between the iliac vessels right into the inferior epigastric artery. So that is the area which you don't do anything, and that's called the corona mortis. That's called it's a dangerous thing, right? So next, what do? Is that now we have identified a space which is called the space of Bobrow. Now the space of Bobrow is the space which is lateral to the inferior epigastric artery. Okay, this is a potential space, right, which you have to clear out all the way to the almost to the entire anterior spine. Okay, which will help you to put the mesh at that area. Okay, and we have also identified a black circle which you can see in the middle, which is called the space of Reitzius. Now, the space of Reitzius was the space which is bounded by the two inferior epigastric arteries. So basically, you have to clear the space of Reitzius and the space of Bobrow on both sides. And this is the blue circle which you can identify properly, which is the myopectoral orifice of Frouchot. Please mind one thing over here, is that the only thing which you can identify with myopectoral orifice of Frouchot, you will not see separate landmarks. Perhaps you can see the lateral border of the rectus abdominis, and you can see the iliopsoas. Other things will not be very much visible. Okay, especially the transversus, that arch fibers which is there superiorly, when the picture fibers are visible, because those are more anterior structures and you are seeing it posteriorly. Okay, now this is called the myopectoral orifice of Frouchot. Now you can see that this is actually covering both the direct, indirect and the femoral spaces. Now this is the area which you want covered, and this is the why you have to a posterior repair covers all the areas, potential areas of myopectoral orifice of Frouchot, with direct, indirect, as well as the femoral. So there we have put the mesh. See the mesh, which I'll tell later, that it crosses the midline. Okay, because you will have to get the space of almost 4 to 5 centimeters away from the defect on all sides. So medially 4 to 5 centimeters away from the defect will sometimes like to cross the midline. Okay, so even if you do a unilateral repair in any laparoscopic, make sure you don't focus on that. You have to cross the midline and make the space. You have to basically clear the entire space of Reitzius, the black circle. So if you're doing something on the right, you have to go all the way and you have to clear that area also so that your mesh properly fits over there. Okay. And you can see this. I put some green circles and red circles. The green circle with the X is basically where you can put the trackers. Note that I put one tracker is on the Cooper's ligament and one tracker above the iliopubic tract. Okay, the second tracker of the iliopubic is sometimes not necessary. Okay, but the most necessary thing is the Cooper's, and the red X that you see over there, that is the area we should not put any tackers or sutures to fix the mesh, because that is in the triangle of pain and the triangle of doom. So below the iliopubic tract, no, there's no sutures or tackers to be put. You put one which is the most consistent on the iliopubic, on the Cooper's ligament, and one, if you would require, you put it on above the iliopubic tract. I normally put only one, and that is the only way I put is in the Cooper's ligament. There are some authorities, especially in TEP, they don't put any tackers at all. They roll out the mesh and they bend it properly and just come out. Okay, but don't say that in the examination. Just say that I put one stitch in the Cooper's ligament to fix my mesh. That is it. Right. So now I go to the ports of TAP and TEP. Now the ports of TAP, you can see is the black ones. Normally the surgeon stands on the head end with the assistant. This is the screen. Okay. Now I put sub-umbilically 10 mm. This is the camera port, and the right and left is 2 fingers bed and 3 fingers beds, or 3 finger, 2 finger beds in the lateral working port, and the left lateral and right lateral working ports on left and right hands. For tap, I just put the same orientation, but the space but a little bit above the umbilicus. You can say as an area which is we divide the line between the umbilicus and the xiphosternum, and the above 2/3, below 1/3. It is not, it's an arbitrary point, but I normally put it 3 to 4 centimeters out the umbilicus, the camera port, and similarly the left and right working port, and everything else remains the same. Okay, this is my tap and tap, right? Now for TEP, there's some authorities, because if the hernia is on the right side, they will stand on the left side of the patient with the assistant on the right side, and they will put one camera over here, 10 mm, second camera above the symphysis pubis 5, and one in the middle, the right and left working hand port. So this is something with some authority. If you've seen this being used, say this. If you're confident of saying this, say this. Okay. Now, the difference between tap and tap. The tap is what you mean as a transabdominal pre-peritoneal repair. See, we are going to the pre-peritoneal space, because in the pre-peritoneal space only you can find out the space of right CS and the space of Bobros, right? We do the dissection over there. So, transabdominal pre-peritoneal space means what? First, I go inside the abdomen first. After going inside the abdomen, I take the peritoneum and I incise over here and reach the pre-peritoneal space. So from inside the abdomen, go on one layer up by cutting the peritoneum layer and reach the pre-peritoneal plane. This is the plane of dissection for all inguinal hernias, whether tap or tap. Okay, pre-peritoneal plane. So tap is what? I go inside the abdomen, inside the peritoneum, okay, and then I incise the peritoneum and go one layer up in the pre-peritoneal space. I mean before the peritoneum, pre-peritoneal space, and then I put the mesh. I do the dissection and I put the mesh. Okay. So what is tap? Tap is total extraperitoneal. Means that total means you don't get the peritoneum at all. The abdomen is not entered at all. So you go in a particular way, which I will show you. You go direct to the pre-peritoneal space, right? And then you put the mesh over here. You do the dissection. You dissect the space of right CS and the space of Bogros, and then you put the mesh. You do something, put the mesh. Now the concept of arcuate line is there, which I'll just tell you over here, but then I'll go more deeper when I tell you the anatomy of the abdominal wall, when I talk about the ventral hernia. But in this, you see that arcuate line is the line in which where the posterior rectus sheath becomes deficient below the umbilicus. Okay, and the posterior layer is only from the transversalis fascia, which you see over here. So this is a line over here, okay, just below the umbilicus, where the posterior rectus sheath, okay, becomes deficient. So above the umbilicus, the entire structure is like this. There is the rectus abdominis over here, the external oblique fascia, internal oblique fascia, transverse muscle. The external oblique fascia continues as the anterior rectus sheath. Internal oblique fascia divides into two. The anterior lamella goes and forms the anterior rectus sheath. The posterior lamella forms with the fascia of the transverse muscle from the posterior rectus sheath. Whereas below the arcuate line, what happens is that since the posterior rectus sheath becomes deficient, all the three affluents goes from the anterior rectus sheath, but there's no posterior rectus sheath. There's only transversalis fascia over here. Okay, so what we try to do over here is that we enter the plane, pre-peritoneal space below the arcuate line. Okay, right. So I'll tell you how they do it. So you see again the white triangle over here and the red arrow over here. Now, we actually, when we do a TEP, the question is that how do you enter the pre-peritoneal space? This is why you enter the pre-peritoneal space. You do a 12 to 13 mm incision below the umbilicus, right? And then the first layer that you cut is the skin, right? Then you find the yellow is the subcutaneous fat. Then you remember we are just below the umbilicus over here. So we are above the arcuate line. So the posterior rectus sheath and anterior rectus sheath both are there. So the orange line that you see is the anterior rectus sheath. Right? So we cut the skin. We remove the subcutaneous fascia, we see a white glistening structure, which is the anterior rectus sheath. Now we incise the anterior rectus sheath, and then we get into the muscle. So in the muscle, what we do is that we don't cut the muscle. We move the muscle to one side, right? We just move the muscle to one side because you don't want to cut it. Why? Because it bleeds. If it bleeds, it occludes the small area, you will not be able to identify anything. So do not cut the muscle. From the midline, you just take a retractor and just retract it laterally. You'll find, after you go in a depth, you'll find the posterior rectus sheath, which you can see over here. This is the posterior rectus sheath. Okay. Once you see the posterior rectus sheath, you just keep it retracted, the muscle, and you just put the port, 10 mm port in without your operator. Okay. Just put the only port in. Right? Once you put the port in according to this triangle, okay, and you put 10 mm or 12 mm of pressure or air over here, you'll find this space opening up. Now, this is the space that you have to go for any TEP, and you reach the preperitoneal space for any TEP surgery. Now, this is a very good, important thing which I've taken from Sir's book, Chief's book, Paranivalu's book, which if you have Dr. Paranivalu's book, you'll find it over here. It's a very, very good book. Okay. He was my boss in JAM, so I know. So basically, you put the port in over here, and then you just tilt the port this side, becomes like this, and you give air inside. And then you'll find the entire space opening up. For this one thing, new thing called the E-tap. E-tap is that this white triangle over here, I go back to the left hand figure, which is a little bit lateral to the midline, almost to the subcostal region, 2 to 3 finger breadth below the subcostal region. You again go through the skin, subcutaneous fat, anterior rectus sheath, right? And the muscle. Now in this, you have to go through the muscle. Sometimes you have to optic port till you reach the white glistening of the posterior rectus sheath, and then you start dissecting over here. And then slowly you reach the arcuate line. After the arcuate line, the posterior rectus sheath becomes deficient, and then you reach the preperitoneal space. See, the trick is to reach the preperitoneal space. How you reach the tap, and E-tap is almost the same. You don't incise the posterior rectus sheath. You start dissecting, or you start giving gas in the posterior rectus sheath. The sheath will open up. Now, there's an important thing to note over here also is that you see there's a posterior rectus sheath which is coming like this, and then this is the arcuate line actually. This yellow thing, arrow is the arcuate line, okay? And it becomes deficient, and it continues as the one thin line that you see over here as the transversus fascia. I told you that's the thing which is there posteriorly is deficient. So, when you're above the arcuate line, the area where you're actually giving the gas, okay, is the retrorectus or retromuscular plane. So, you do dissection in the retromuscular plane, right? And below the posterior rectus sheath is the preperitoneal plane, right? Now, you move downwards, and after the arcuate line, you'll see there's a transversus fascia over here. So, it is just one cell layer thick. So, potentially, there should be a retrorectus space over here, which is above the transversus fascia, and the preperitoneal space, which is below the transversus fascia. But it's very difficult for you to see it because the transversus fascia actually gets it's very difficult for you to find it out. Okay, so it becomes a preperitoneal space. You can see that entire surgery takes place in the preperitoneal space in the tap, right? The only way you have to know about this transversus fascia is when you in the tap plane, the muscle above, which the rectus abdominis, should not be bare. If there's one thin layer of fascia, it means there's some part of transversus fascia which is up, and you basically dissect in the preperitoneal plane. Okay, now how to make a space in preperitoneal space? So this is something which is, so first you put the, some people, you have, you can make it with a balloon. So as soon as you reach the the preperitoneal space, you put a balloon in and then you expand the balloon, okay, and then you take it out and the preperitoneal space is formed. But then sometimes what I use is sweeping movement of the camera and gas insufflation. Okay, so once you reach the preperitoneal space over there, just put 10 to 12 mm of pressure of gas, and the entire space opens up and just do a sweeping movement. Okay, and this is the way. So, for example, if this is the hernia on this side, okay, so you have to identify the pubic symphysis. The picture I've taken from a good study which you all should know about just come out about describes the spaces. When you see this area which is over here with the symphysis pubis, which is known as the lighthouse sign. So this is what I wanted to show you from taking this picture. It's a study that has come out from Brazil. This is what you call the lighthouse sign. So identify the lighthouse signs of symphysis pubis. So over here, if this is symphysis pubis, is the hernia. You put the thing. You not see the hernia first, especially in TAP. You find out the symphysis pubis, which is the white glistening structure, which is known as the lighthouse sign. Now there's a TAP view that you get. In TAP view, obviously you're inside the abdomen. In the abdomen, you'll find the median umbilical ligament, which is there, which is the condensation of the urethus, and the lateral, the medial umbilical ligament, which is this. Okay, this is the medial umbilical ligament. This is the medial umbilical ligament, which is the condensation around the umbilical artery, and then you see the lateral umbilical ligaments, which you find, which is the condensation around the inferior epigastric artery. So as soon as you enter the TAP, you will find you have to identify these three structures. Also the urinary bladder. Urinary bladder is important because you have to make sure the bladder is totally collapsed. Okay, you don't want to do it. Do the surgery, especially prepared space or bladder full. Okay, so again, when you see the medial umbilical ligament, another picture that I found is very, very good. Which is the anatomy of groin from the posterior approach by Bittner, in which you will again I told you identify the three things. This first will be the inferior epigastric artery, which can be seen over here, right? The gonadal vessels, which you can see like that, going laterally, and the going towards the medially or towards the bladder will be or towards the prostate. What is going? Vas deferens. So this is again the three structures which I told you in this thing that you can find out, right? Again, you do a TAP peritoneal insertion. How do you do a TAP peritoneal insertion? The TAP peritoneal insertion is that you go 5 centimeters above. You start from 2 to 3 centimeters anterior and medial to do the anterior iliac spine, and then you start inciting the peritoneum. From lateral to medial, you come towards the medial umbilical, lateral and medial umbilical ligament, right? And then once you put it down, you enter the preperitoneal space. When you enter the preperitoneal space, you have to go lateral. You have to go medially towards the space of Retzius will be over here, and then you identify the space of Bobros will be here. So you do dissection and you have to clear all these areas. Okay. Right. Now, what is the fundamental difference between TAP and TAP? The fundamental difference between TAP and TAP is that in TEP, the peritoneum is not entered, or the intra-abdominal peritoneum is not entered. Lesser space of maneuverability in TEP, not suited for large scrotal hernias. Okay, so this is one of the relative contraindication for TEP is that when you deal with large scrotal hernias, you actually don't have that much space to reduce the hernia. Okay, hernial sac. So when a large scrotal or complete hernias are there, you prefer to do a TAPP because the entire huge spaces there inside the abdomen, you can take down the entire sac inside the abdomen. So it is not a problem. And always remember, TEP is not suited for previously diseased pelvis. Like what? There's some kind of prosthetic operation that has been done on a previously irradiated pelvis. And then it's very difficult to open up the peritoneal space. In TAP, it is much easier because of the maneuverability. You have the entire room inside the, pneumoperitoneum for you to reduce the sac. So your hands can move more freely. It's easier to learn. Okay, you can identify properly the median umbilical ligament, medial, and tailor your incision and everything accordingly. Bilateral hernias can be seen without any further dissection. Okay, it's a very important point. Because as soon as you put a camera in, you can see the both groins. You can see both whether there's hernia present both sides or not. In TEP, you're only entering one side and you're dissecting the other side to see whether the second side there's a hernia or not. So now we'll go to the tricky questions which can be answered. The international guidelines for groin hernia management is something which all of you should download. It is a very big document, but I have tried to put it in one space so that you know the most important things. Now, the reason I told you about this guideline is that whenever someone asks you these type of questions that follow, just say, sir, according to the international guidelines for groin hernia management 2018. Okay. Now, they ask you which diagnostic modality is the most suitable for diagnosing chronic pain after chronic groin hernia surgery. Okay. So, you will say something like, or what is the diagnostic modality which is used most suitable, not chronic pain, basically to diagnose groin hernia surgery. Okay. So I told you about the USG, how will you say it? So the correct way to say it is that, sir, clinical examination alone is recommended for confirming the diagnosis of an evident groin hernia. Okay, is strongly upgraded, right? Now, if let's just see the wordings over here. Clinical examination, that means you're seeing the swelling, okay, you're seeing reducibility, you're seeing you can't get above the swelling, right? All those why it's a hernia. Confirming the diagnosis of an evident groin hernia. Okay, that means you are already clinically, you can know that is a groin hernia. Then only clinical examination alone you can go ahead with the hernia surgery. Okay, nowadays they don't do it, but if the question is asked. Now, clinical examination use is combined when in most suitable for diagnosed patient with vague groin swelling. Okay, where you can't make out, but the patient is saying that he is hernia. Possible of occult or recurrent groin hernia. So occult is meant hidden. You don't know. You're not sure. Then you do C and US. And recurrent, any recurrent hernia, you do a US. Dynamic MRI or CT scan can be considered for the evaluation if US is negative or non-diagnostic. So understand one thing. If it's evident, you can see, in your clinical examination, you can see and you can prove that it's a hernia. You do only clinical examination, okay? And you go ahead with the surgery. If it is not evident, okay, it is occult, then you do clinical examination plus US. Or if it is recurrent, any recurrent, it is evident or non-evident, clinical examination plus US, right? Now, if US is also unequivocal, then you go with the dynamic MRI or a CT. Right now, regarding the chronic pain of this situation, okay. Now these are the two questions. The use of US guided nerve blocks is suggested as most suitable for diagnosing chronic groin pain after inguinal hernia surgery. Okay, so when the patient comes on chronic groin pain, you have to go with the US guided nerve blocks. Okay, it can diagnose or not diagnose. US CT and MRI scans are helpful in identifying non-neuropathic cause of chronic groin pain. Okay, what are non-neuropathic cause of groin pain? Is mesh-related pathologies, recurrent hernias, neuromas occasionally. So find out which is the nerve, which is the neuropathic and non-neuropathic. In non-neuropathic pain, you do a US CT and MRI. What are non-neuropathic? It's mesh-related pathology you're suspecting, a recurrent hernia that might be there with impinging on the nerve, or a neuroma that is there. Okay, then you go for US CT or MRI. Otherwise, you have to go through a US guided nerve blocks to find out which area and you treat it accordingly. So this is actually two questions. Okay, so when you do, when will you do a USG scan in a hernia? Working off on a hernia, you say yes, I'll do a USG scan only when I cannot make out clinically. There's not a clinically evident hernia, though the patient says he's got a hernia. When there's a recurrent hernia or there's an occult hernia, I'll do a US. When you do a CT and MRI in hernia as a pre-op, when after this chronic, recurrent hernias or this occult hernias, after despite doing the US, I do not know. Then you go for a dynamic MRI or CT scan. Regarding the nerve pain after hernia surgery, okay, you go for a US guided nerve blocks in neuropathic pain. In non-neuropathic, I go for a CT, MRI or US to find out whether any mesh-related pathology is there, the recurrent hernia is there, or neuroma or occasional distal. In asymptomatic hernia, so when to do a surgery, whether to do a surgery in asymptomatic hernia, so according to the guidelines, if there's low complication risk because there's no risk of any incarceration or strangulation in asymptomatic or minimally symptomatic men with inguinal hernia. Okay, emergent repair of incarcerated or strangled inguinal hernia in men is associated with higher morbidity and mortality compared with elective repair in men with symptomatic chronic hernias. And the crossover rate, when does the asymptomatic from the symptomatic in men with minimally symptomatic inguinal hernia is high due to the development of symptoms, mostly pain. So basically, the way to answer this question is that what they'll ask you, the question will be framed like in asymptomatic hernias, what will you do? It says you have to answer whether you go for a hernia surgery or not. You will have to answer it this way, sir or madam, whoever you're giving the examination to. Sometimes the asymptomatic hernias can be, which is relatively easier to do, can be crossed over, can have complication later in life. Okay, which will be difficult to do at that time, right? And it will lead to a bigger operation and more suffering for the patient. We will do a elective hernia surgery on that side. But yes, the patient should be explained this, and if he chooses not to do at that time, despite knowing this risk, you should let it be. This for asymptomatic hernias on one side. So most men with minimally symptomatic asymptomatic hernias will develop symptoms and require surgery, because invariably the hernia never reduces; it goes on becoming big. So your first argument you lose. So although most patients will develop symptoms and need for surgery, watchful waiting for minimally or asymptomatic hernia is safe, since the risk of hernia complex is low and can be recommended, but despite you leave it, you explain it to the patient concerned that this will not reduce, this will ultimately, you will require a surgery later in life. Okay, now this is the way you should handle this question. Which non-mesh technique is the preferred repair method for inguinal hernias? The shoulders technique has lower recurrence rate than other strong repairs and is common in non-mesh inguinal hernia repair. Okay, in some conditions in which you don't do mesh repairs. Which is the preferred repair method for inguinal hernia? Mesh or non-mesh? A mesh-based repair technique is recommended for patients with symptomatic inguinal hernias. We strongly recommended. Which preferred open mesh technique for inguinal hernias, lactate test, or any open pre-peritoneal technique? In open surgery, there's insufficient evidence to recommend a pre-peritoneal mesh repair over lactate repair. Okay, so you can do either, whatever you're comfortable in. Is TAP or TAPP the preferred laparoendoscopic method? In laparoendoscopic inguinal hernia repair, TAPP and TEP have comparable outcomes. Hence, it is recommended that the choice of technique should be based on surgeon skills, education, and experience. So you can see either. Although very rare, the trend in TAPP for more visceral injuries, because you are there in inside the abdomen. But please note, in TEP, there's more hidden visceral injuries. Okay, because you don't know, you can't see it, you can't diagnose the visceral injury over there. Okay, although very rare, there's a trend in TEP for more vascular injuries. Okay, although very low in TAP, the frequency of port site hernias is higher. Please do not say this in the examination. Okay, right? Just keep it at this. Know this. Right? Good. When considering the recurrence pain learning curve, postoperative recovery cost, which is preferred technique for inguinal hernias, best open mesh, lactate or laparoendoscopic TP TAP technique. For male patients with primary unilateral hernia, a laparoendoscopic technique is recommended because of a lower postoperative pain incidence reduction, chronic pain incidence, provided the surgeon has specific and sufficient resources available. However, there are patients with hernia catches that warrant a lactate first choice is strongly updated. Okay, so in this kind of question, just say that whatever the surgeon is comfortable in, they can go ahead and do it. Okay. In the exam, say indication for lap repair will be bilateral hernias and recurrent hernias. In patients with primary bilateral hernias, a laparoendoscopic approach is recommended and provided the expert is available, and in femoral hernias. Okay, so I've got many ways of, the questions come, they give a particular situation in which they say a large, and the best way to answer these questions is that, whatever the surgeon is comfortable in, you do it. There are some indications with a TAP is preferred over TAP. TAP is preferred over TAP. If TAP is preferred, is because when there's a large scrotal hernias, when there's bilateral hernias, you do a TAP, you can see both, right? In a previously irradiated pelvis, you do TAPP rather than TEP. But this is something which you should know. But whether you do an open and laparoscopic, it depends on the surgeon's expertise. Okay, especially when there's obstructed or something like that, you try doing a TAP before the neoperitoneum. Most of the time, these obstructed things they reduce by itself, and you can proceed with the TAPP. But most strangulation, you have to go with the open repair. In case when there's an occult contralateral inguinal hernia is seen during TAPP, will it become symptomatic if not repaired? It is recommended that the contralateral joint be inspected at time of TAPP repair if a contralateral inguinal hernia is found and prior informed consent was obtained. So I will tell you one thing, and this of experience is that, see, what happens is that sometimes you take a consent for only right inguinal repair, okay, especially in laparoscopic, and then when you put the camera in the TAP, you will see, oh my god, there's a small hernia over there which went totally undetected. Okay, what will you do at that point? Because you have not taken the consent for the other side inguinal hernia repair. So I always do by good practice is that I say that sometimes when I put the camera in, I might find it on the other side. So I'm taking the one side for both sides, right? But if the patient says no, if you see don't do it, then don't do it. Okay, unless this is the most important, unless the prior couldn't obtain, do not do it. Okay. The mesh characteristics, fatness and pore size have an impact on outcome. The use of so-called lightweight meshes in inguinal hernia surgery that open and laparoscopic may have some short-term benefits like reduced postoperative pain and shorter convalescence. We're still in the hernia guidelines, so you can say that. If using mesh fixation, what type should be used in PEP and TAP inguinal femoral hernias? Traumatic mesh fixation, which is called TACers, is recommended in all patients with large direct hernias, M3 and EHS classification undergoing TAP, P and PEP to reduce recurrence risk. Okay, I suture, so I don't use TACers, but you can use this. If they ask you what is better, just say if you're comfortable suturing, I use suturing. If you're comfortable with TACer, I use TACer. But what is more important is that you have to fix the mesh. That is more important than whether you do a TACers or a this thing. What about the antibiotic prophylaxis? In open mesh repair, administration of antibiotic prophylaxis in average risk patients in low risk environment is not required. So remember that in open mesh repair, for example, in an average risk patient, in a low risk environment is not recommended. Okay, but if you're doing it in a high risk environment, but the patient you have a capacity of, he has a tendency of having infections, then you have to put an antibiotic. In laparoscopic repair, any patient, any risk environment, antibiotic is not recommended. Okay, this is the guidelines. Does local anesthesia influence outcomes after open repair of reducible inguinal hernia when compared with general or regional anesthesia? Local anesthesia is recommended for open repair of reducible inguinal hernias provided surgeon experienced in local anesthesia use administer the local anesthetic. So even only when you're expert in this, can you do it? Okay, then else don't do it. What is recommended duration of convalescence following uncomplicated inguinal hernia repair? Physical activity restrictions are unnecessary after uncomplicated inguinal hernia repair and do not affect recurrence rate. So this question can be framed for you. After postoperative patient discharge, how long rest should you give? This is the answer. Physical activity restrictions are unnecessary after uncomplicated inguinal hernia repair and do not reflect recurrence rates. Patients should be encouraged to resume normal activity as soon as possible. Right? This is uncomplicated, okay? Does intraoperative parenteral fluid restriction reduce urinary retention risk? Minimizing the amount of parenteral fluids given to patients undergoing inguinal herniorrhaphy may result in lower incidence of urinary retention, especially for older age individuals. If your hernia list, you put him at the end of the day, from morning they're getting so many fluids and the poor person is in the preoperative trolley that he cannot go and do urine, or intraoperatively he gets more fluid. Ultimately, he has, especially if he has occult symptoms of bladder outflow obstruction, which has not been investigated, he might run into a urinary retention risk. Can sexual dysfunction following hernia repair be treated surgically? Painful conditions interfering with sexual function can be improved by operative techniques used for treatment of neuropathic pain, release of spermatic cord, and mesh removal. Okay, so you have to be very wary of that, which might come to you saying that he's got pain during sexual dysfunction. About seroma, the risk factors for postoperative seroma formation include scrotal hernias, coagulopathy, and congestive liver failure. Inverting and fixing the lax fascia transverse during the mesh repair is something which you do. What we do is that sometimes during direct hernias, you find a huge lax fascia transversus there. We just take the lax fascia transversus, which forms a part of the sac. We just take it in and we do an imbricating suture, and you reduce the sac size. When you reduce the sac size and fix it to the Coopers, what happens is that there's no seroma that is formed. What's the risk factor of chronic postoperative inguinal pain? Chronic pain should be defined as bothersome moderate pain impacting daily activities lasting more than 3 months postoperatively. Okay. So chronic pain post inguinal hernia repair it should be a bothersome moderate pain which impacts your daily activities more than 3 months postoperatively. If it persists more than 3 months, that means it is diagnosed as CPIP. CPIP risk factors include young age, female gender, High preoperative pain. So patient preoperatively has pain, has to be counseled. That you postoperatively also might have pain. Early high postoperative pain, recurrent hernias and open hernia repair. Okay, there's a risk factor of CPIP. Does mesh friction to the pubic bone increase incidence of acute or chronic pain? Yes, mesh friction to the pubic bone is not recommended since this leads to an increased incidence of chronic pain. So pubic bone avoid, put it in the Cooper's ligament. What should be the initial approach be in inguinal hernia repair with chronic postoperative pain? See, a multidisciplinary pain, a multidisciplinary team has to be there to manage the chronic pain. Pharmacological and interventional measures, including diagnostic and therapeutic nerve blocks, which I told you, we should continue for a minimum of 3 months, minimum of 6 months after hernia surgery. So this is something we have to do. Okay. In patient with intestinal strangulation or concurrent bowel restriction, clean contaminant is mesh-based repair recommended. Mesh-based repair is suggested in emergent bronchial surgery with a clean or clean contaminated surgical field. Okay, so if it's only clean or clean contaminated surgical field, you put mesh repair. Some people will ask about whether there is, serosal tear is there. Yes, serosal tear is okay, provided there is no enteral contents over there. Now I go to the ventral hernia very quickly. I'll take half an hour to 45 minutes for this. In ventral hernia, again, as in all hernias, the most important is the swelling and the pain. Be very wary of the swelling and the pain. History is what? Again, mode of onset, progress, size of onset. So, this is the approximate present directions. Note if the operation is less than 1 year. If it is less than 1 year, okay, you have to describe the operation in the history of present illness. If it is more than 1 year, go to past illness, but it's better to describe the entire sequence in present illness. Emergency and elective, whether the operation was emergency and elective, I'm talking about incisional hernias. Nature of operation which is there. Okay. Post-op recovery, how it was. Any history of chronic cough, abdominal distension, wound cells, secondary suturing, duration of hospital stay, and ICU stay. So whenever the patient is not well, it's in the incisional hernia that you're getting, you have to find out what is the operation that has been done before which caused that incision. Okay, whether it's an emergency or elective operation, what the nature of the operation. Nature means that whether it's like laparoscopic operation for oncosurgery, emergency surgery or not, or post-op recovery, how it is. History of, this is not history of whether he has chronic cough from before. This is post-operatively, did you have any cough, violent coughing episode? Did you have any abdominal distension? Did you have any wound essence? Did you have any secondary suturing? Did you have duration of hospital stay or ICU stay? Okay. Now the cough over here, I might have told you of chronic cough. The cough over here is not actually chronic cough. You have to say any violent episode, violent coughing which is there in the immediate post-operative period. Okay. Now length of ICU stay. Now the time gap between the operation and the appearance swelling is very, very important because you have to find out whether there is any, whether it was a occult burst abdomen or not. Okay. Aggravating and relieving factor, again, is the same as all hernia, standing up, walking, straining and lying down. Pain, if you describe the pain, onset, duration, site, character, radiation, relation of pain to swelling, aggravating relieving factors. As I told you before in inguinal hernia, straining factors, very, very super important. Chronic cough, constipation, difficult administrations, okay? Chest, bowel, urinary. Difficult administration, you have to say all, urinary frequency, urgency, knock-in, everything. Bladder and bowel habits and systemic symptoms, okay? Personal habits is important, family history, treatment history, where abdominal binder belt is there. Examination. Please know that rectal diversification is different to wall defect. Okay. So in an examination, this is the abdomen, say. Okay. If this is your abdomen, here's your umbilicus, right? Say the patient has a financial and there's a hernia over here. Okay. Right? Now let's do another incision. Let's say the patient had a midline operation before and the hernia is occurred over here. And patient had a, say for example, maybe a stoma site over here. Okay. Now, whenever you're seeing an incisional hernia, what you have to describe is not only the scar and the hernia over here, you have to see the entire abdomen. Whether there's any occult hernias over there in the stoma site or any laparoscopic site with that put. You have to mention all of them. Secondary is that you have to find the difference between rectal divarication and different to the wall defect. Wall defect is that will be evident once you reduce the hernia, and then you tell the patient to lift their leg up straight or lift their head up, and then you can find the indentation in the abdominal field, which is there. Okay, but some patients have divarication of recti as well, which is in which the rectus becomes loose over here, lax. Okay, so you have to make the separate to this. So especially in incisional hernia case, a lot of people have not only a wall defect and the hernia, everyday hernia, because you'll see in a divarication also there. And some students in their nervousness describes the entire divarication as the hernia, which is wrong. Okay, and which is a trap, which you should know. Okay, now as we move forward, mention the scar in the abdomen, healing primary and secondary. Let me say the abdomen is, whether the scar has healed in the primary, secondary, or intention, whether any escalation is present over there. Also see the back of the torso. Also, which turn the patient, see in the back whether there's any kind, there's any kind of skin changes due to the garter belt, or any kind of issues are there or not. Diagnosis would be a 45-year-old woman has an incisional hernia through a phalansteal incision. I'm just giving an example. Following a cesarean delivery, you have to say what kind of operation was that. Content of it being intestine and is reducible. And over here, add with any kind of divarication is there or not. Okay. You can see the EHS classification. And always check for other scars, and if there is any potential hernia through them, don't mention it. So you can say that there's a laparoscopic incision scar which has a small hernia of 2 centimeters over there in the, you can say, right upper abdomen. This is also very important. Okay. Now this is the EHS classification. Now the EHS classification is basically. I put on the EHS classification, I think so. Just hold on. I'll come to the EHS classification later. I think I have another one. Just hold on. Yeah, I'll come to the EHS classification later. I put the wrong slide. Yeah. So what is the important history in incisional hernia? Important history in incisional hernia is that what is the type of operation? 1, right? Whether an elective or a emergency operation. 2, what is the incision? Suture material used, surgeon's expertise, any intraoperative complication. 3, post-op period, yes, violent cough, all these things, abdominal distension, or required catheterization for urinary catheter for any retention. 5 is wound infection, hematoma was present in the initial operation or not. Any gaping of wound is there or not. Period of post-operative stay in the initial operation. Post-op cough, straining and distension, history of previous abdominal operation. These are all very important history in incisional hernia. And then, of course, it depends on the patient factors, whether the patient has diabetes or not, malnutrition, anemia, smoking or staining factors. These are one of the risk factors for having any kind of incisional hernias. One of the causes can be a poor surgical technique in the initial operation, non-anatomical incision, which is vertical more than transverse. Method of closure, layered closure is higher than mass closure. Okay, the incidence of hernia in a layered closure is much higher than mass closure. Suture material, non-absorbable, over-absorbable, right? Suture technique, tension, if the abdominal close under tension or not, and whether drainage tube has come out of the main incision wound or not. Okay. Pre-op screening factors, whether the patient already had any chronic cough or prostatitism or constipation. Post-op screening factors, where the patient had an episode of violent cough or post-op urinary retention. General factors, as I told you about diabetes, mellitus, malnutrition, etc. And tissue factors, where the patient has any kind of collagen vascular diseases. How will you manage? This patient needs an operation, chance of obstruction, cosmetic. Okay. Address associated symptoms like diabetes, smoking, chronic cough, and prostatitism. Skin conditions, if it's there or not. Obese weight reduction. In obesity, he has to have weight reduction, which contributes to the hernia. The USD C-series scan, you have to do it because in incisional hernia, you will have to do any kind of radiology to find out the content of the hernia, whether addition is present or not. You will have to plan the operation, and an optional endoscopy to be done. Okay. Now, before I go to the treatment of ventral hernias, I'll have to tell you about the anterior abdominal wall. Okay, how does it? What is it? Because it's very, very important for you to know, because nowadays there's a lot of different ways to treat an abdominal wall hernias, okay, including incisional hernias. So basically we know that the abdominal hernia, the lateral part of the anterior thigh, there is the skin subcutaneous tissue, the superficial is the external oblique muscle, internal oblique muscle, transverse abdominis muscle, and then the peritoneum is there. If you trace it medially, okay, then aponeurosis which forms, and then it splits into two. The aponeurosis from all three must split into two, and because the anterior and posterior rectus go the rectus abdominis muscle, and then again it fuses again with the opposite side and forms the linea alba. So basically, the anterior abdominal muscle musculature anatomy, you'll have to know three important lines. First line you have to know is the linea alba. The linea alba is called the white line. It's a single midline fibrous line in the anterior abdominal wall formed by the median fusion of the layers of the rectus sheath medial to the bilateral rectus abdominis muscle. It attaches to the xiphoid and xiphoid process of the sternum and the pubic symphysis. So this is the picture you can find. This is the midline fibrous line right from the xiphoid in the sternum to the pubic symphysis, right? Now, what is the linea semilunarius? The linea semilunarius is a vertical curved structure that rides on the lateral edges of the rectus abdominis muscle. Okay, I told you the three rectus abdominis which comes together like this area. This area, sorry. Okay. This exactly is a vertical curved structure that runs around the lateral edge of rectus abdominis muscle in the anterior abdominal wall. It is a site of union where the tendons of the lateral abdominal muscles, which are the external oblique, internal oblique, and the transabdominis meet surrounding the rectus, meet in the sheath surrounding the rectus abdominis muscle, also known as the rectus sheath. So this is, if you say this is the linea alba, this area is called the linea semilunarius. Okay, where the lateral muscles aponeurosis meet the middle and again it diverges to form the anterior posterior rectus sheath. So that area is called the linea semilunarius. What is the linea semicircularis with the arcuate line? The arcuate line of linear rectus sheath, the linea semicircularis or the arcuate line or Douglas line is a horizontal line that demarcates the lower limit of the posterior rectus sheath, which is like this. This is the linea alba, linea semilunarius of both sides, and where the posterior rectus sheath becomes deficient, that becomes the arcuate line. Okay, this is not both as you've explained before. So this is the arcuate line. The area above this arcuate line and the area below, the area above, this is the way it is. You can find the three layers are there. Anterior external oblique continues the posterior rectus sheath above the arcuate line. The internal oblique splits into two. The anterior lamella goes with the aponeurosis of the external oblique to form the anterior rectus sheath. The posterior lamella goes aponeurosis with the posterior established on the posterior rectus sheath. This is above the arcuate line. Below the arcuate line, all three goes above and form the posterior rectus sheath. Anterior rectus sheath, the posterior rectus sheath is deficient over here, only formed by the transversalis fascia. There, the linea alba over there, right in the middle. Okay, and the linea semicircular is the blue line. You can see the blue circles. If you see a head on, it's like this. Okay, now this is the arcuate line. I have done this, so you know about this. I'm not going to go. Now they ask you where will you put the mesh. Okay, I just go to most important things they ask you in the exam. So this is what you call onlay mesh. Onlay mesh is some mesh you put it. You see the blue line above the anterior rectus sheath. Okay, inlay would be the mesh you bridge the defect. Okay, retrorectus would be you are above the arcuate line, right, and you put the mesh below the rectus muscle, but above the posterior rectus sheath. Again, retrorectus is what? You are above the arcuate line and you are putting the mesh below the rectus muscle and the posterior rectus sheath. Okay, below the arcuate line, the posterior border of the retrorectus space is not there. The posterior rectus sheath is not there. So what you say? Below the rectus line, when you put the mesh, and when do you do that? In TEP. Okay, and TAPP, you put this mesh in the preperitoneal space. Right? Okay. And this is interperitoneal, which is you do in IPOM. Right? This is very clear. Now Now, again, this is something which I told you before. I'm not going to just repeat. So, the EHS classification. The EHS classification is something which you have to describe all your ventral hernias, especially intestinal hernias, right? Now, there's some anatomical landmarks you should know. This is the leafy-sternum, right? This will be the umbilicus, and say this is the symphysis pubis. Okay. Now, if you take if you take the leafy-sternum level and put 3 centimeters below the leafy-sternum level in the medial side of the abdomen, this area, any hernia in this area is an M1 hernia. Now, if you take another line, which is 3 centimeters above the umbilicus and 3 centimeters below the umbilicus, any hernia over here is M2. Now, you put another line below the umbilicus 3 centimeters. So, any hernia above from the line above the umbilicus 3 centimeters to below the hernia 3 centimeters over here is M3. Now, this is symphysis pubis. Any hernia which is 3 centimeters above below the umbilicus and the line which is 3 centimeters above the symphysis pubis over this area is the M4. And any hernia 3 centimeters above the symphysis pubis is the M5. So this M1 is known as subxiphoidal, M2 is known as epigastric, M3 is known as umbilicus, M4 is known as infraumbilical, and M5 is known as suprapubic. Okay. Now, if you go along beyond the linea similaris, okay, which is like this, okay, this is only umbilicus. Any hernia which is above 3 centimeters above the hernia below the subcostal is L1. Any hernia from above 3 centimeters to below 3 centimeters of the umbilicus beyond the linea similaris is the L2. And similarly, any hernia which is below 3 centimeters until the symphysis pubis iliac region is known as L3. So this is subcostal, flank, and iliac. Any hernia which is behind is L4 in the lumbar region. Okay. So international hernia classification of subxiphoidal, M1, epigastric, umbilicus, umbilical, and supraumbilical. Lateral hernias will be subcostal, flank, iliac, lumbar. With recurrent, yes or no. Length, you have to say, width, you have to say. Width is actually W1, W2, W3, you have to say less than 4 centimeters or 4 to 10 and 10 more than 10. Okay. Remember one thing, that sometimes if the hernia is something like this, you have to say this as M1, M2. Okay. If the hernia is something like this, you have to say M1, M2, maybe M3, L1, L2. Okay. So this is the way you should do it. M1, M2, L3. Okay. How would you manage? So you manage the patient needs an operation. Oh, if I went to this side, it's just okay. Surgical options. The surgical option is that you can have an open repair, you can have a laparoscopic repair, right? Laparoscopic intraoperative only mesh repair. IPOM plus is what? Independent only mesh repair with defect closure. So when you close the defect in IPOM, it's called IPOM plus. ETAP is what? Expanded view of total expiratory repair. Okay. Surgical options is that with low mesh, less than 2 centimeter midline defect. Okay. More than 2 centimeter will always require mesh. See, this 2 centimeters is like an arbitrary. Some people say 1 centimeter, or some people put mesh in everything. But say 2 centimeters and say that my department follows this. That's a good escape from whatever the examiner controversy that might say. Just say my department follows this. Incision would be in open, that's transverse the vertical electric incision, stack dissected, content reduced, stack divided, ligated, linear, but 20, 20, we couldn't skin. I'm not going to go with this. It's something which you know, Ripastoffer technique. Okay. The Mayo repair. Okay, these are open repairs that you can do for incisional ventral hernias. I'll just talk a little bit about laparoscopic reparations, which is IPOM, which is the interoperative only mesh repair. So when you do a laparoscopic repair, just stick to IPOM and IPOM plus. Okay, IPOM plus just a defect closure. Don't say anything called TAP plus or anything like ETAP or something. If you have not seen it, just keep quiet. Just put IPOM. They ask you why is it called only mesh repair. You say that it's a misnomer. Okay. because it is actually inside the abdomen, intraperitoneal repair. Okay. But what are the other things, other type of new repair that has come in? You can say that E-type has come in, which is the expanded or extended view total extraperitoneal repair. Okay. Scola and Milos is something which they will not ask you. It is more to do with some people, some small group that does it. So in an IPOM, what do we do? There are two techniques to do an IPOM regarding the ports. One is the surgeon stands on the head end, okay, and like a tap only, but much higher. They put 3 ports like this, right and left hand one port with a hernia over here, and they see it from here, okay. But the more, this is what you're going to describe, and it is there in the examination, there in the books, okay. The surgeon stands on one side, on the left side of the patient, right. This is the hernia. He approaches the hernia by putting the first varus in this area, the palmar space, okay, and they put an interperitoneum. Then after doing the pneumoperitoneum, they put the camera port and then the right and left hand side working port and approach the hernia like this. Okay, this is what you want to describe. This is a 10 mm port. These are 5. These are 5. Difference between IPOM and IPOM plus is that, see, IPOM is that this is from inside the abdomen. They put the mesh over here, but the defect is still there, and they put tackers over here. But in IPOM plus, you close the defect and then you put the mesh, same as before. This is the IPOM and IPOM plus. Right? You can see over there the tackle. This is actually a wrong picture. They have put only this mesh is not used. This mesh is used. Composite. Okay. This I was just taking it from another presentation. What to do and not to do. In E-TAP is something which you should understand, which is you might not say it in the examination, but I'll just take this opportunity to explain it to you. See, what happens is that you have to go towards the retrorector space. Okay. So first, if this is your abdomen, right? Linea alpha. These are rectus muscles. Okay. So basically, you do the port over here. Okay. And then you enter abdomen over here. As you can see, the first thing you'll see is skin, then subcutaneous tissue, then the anterior sheath. So I'm seeing it from the head end over here. Okay. So you probably entered like this, right? So you first see the skin. Okay. Then the anterior rectus sheath. Then you go through the muscle till you reach the posterior rectus sheath. This is the posterior rectus sheath. Okay. Once you reach the posterior rectus sheath, you start dissecting, insufflate, you go towards down till the posterior rectus sheath, you can differentiate at the arcuate line. This is the arcuate line. And you reach the where you do TAP, right? The preperitoneal space. Because why? The posterior rectus sheath is not here over here. Right? Now, then you cross over in the midline, right? You put in another port over here, and then if the hernia is over here, so this port is there. There's another port that you make over here, and it goes right hand, the right side working port, and then you tackle the hernia, right? Sometimes what you do is you do a TAR. In TAR, you do a transverse abdominal release and reach this place. If the hernia is big, okay, and you put a mesh, so you cut the transverse abdominal release, which I'll tell you, and you reach and you go to this place. Why? Because you have to put the mesh. You have to cover the hernia. In large hernia, put the mesh over here. Okay. So this is the E-TAP TAR. Actually, they have done E-TAP plus TAR. Okay. Then again, you can see the expanded view TAP, the same thing. Okay. Scola is something which you don't know. Please read it. There's some don't mention in the examination. Interperitoneal or extraperitoneal repair. Interperitoneal IPOM technique is the established technique. We have to put a composite mesh, which is expensive. Because why? Because in the interperitoneal technique, you have to put a mesh which does not stick to the abdominal organs, especially the intestine, which can cause adhesions, cause a lot of issues, obstructions also. So you have to put double layer mesh. Okay, so the layer which is facing towards the umbilicus, which facing towards not the umbilicus, but the intestine should be non-sticky. Okay, and that itself costs a lot of money. So there's a chance of intestinal obstruction, right? But in extraperitoneal repair, it is a cheap mesh. E-tap is sort of an extraperitoneal repair. Okay, don't just pull over here, say tap over here, tap and tap. You can put a cheap mesh because you don't require a composite mesh over there because the posterior layer is you have the peritoneum, right? So you can put a mesh which you use for inguinal hernia surgeries, okay, which is a huge advantage in our country, cheap mesh. But the problem is that still no long-term results are there. Only thing you can extrapolate the results from an open repair. Of course, you can understand that it is a longer operative time because you have to create the space for which to put the mesh. But in IPOM, you put the mesh inside the abdomen, it doesn't take any time. And of course, another thing is a less chance of intestinal adhesion. Okay. Now, a little bit of component separation of Ramirez. It provides a tension-free closure of large full-thickness abdomen wall defects, 8 to 10 centimeter transversely. In small abdomen might be less thick. You have to understand is that don't put arbitrary measures saying that, above 10 centimeters I'll do a component separation of Ramirez. Not true. In a smaller abdomen, even a 5 centimeter large or 6 centimeter defect, also you have to component separation. Now, a little bit of component separation, already know about section above the armpit line and below the armpit line. Above the armpit line, if you take the slice, so this thing, let us anatomy. Now you can see in component separation, anterior component separation, the small arrow that is going to come, you want to cut this area of the epidermis of the external optic, this red area. Okay, this area. So how we do it is that, so we reduce the hernia from the midline. Then we cut the external oblique up in USC. You can see over there small arrow. We switch out the defect and we put the only mesh. Okay, this is a green mesh that you can put over there. Okay, so reduce the hernia. You can see over there from the midline. Cut external oblique up in USS, right? We switch out the defect and then we put the only mesh. This is what we call the anterior component separation. So we have cut over here on both sides. What posterior component separation? Again, you can see an arrow that has come over here. Okay, and we cut it over here. So what we do? We enter the midline, reduce the hernia, enter the posterior rectus space, and posterior rectus sheath is released from here. Okay, then again, if the myofascial approximation happens, right? There's a difference between anterior and posterior component separation. Now, what happens in TAR is transverse abdominal release. Again, the small arrow has come. That is the area we have to release. So what happens is that first we go from the midline, we enter the posterior rectus space. Okay, we cut the posterior rectus sheath. We flip the posterior, the rectus muscle laterally, and then we cut the rectus, the transverse abdominis release. We release the transverse abdominis over there, and the thing is approximated. You can see we have put a mesh over there after cutting the transverse abdominis here. Okay. So midline to reduce the hernia, inside posterior rectus sheath and enter retrorectus space. Develop a plane, and from there cut the transverse abdominis muscle. Right? On both sides. So this is the TAR release when you put this abdominal side on view. This is the arcuate line. Okay, that's the TAR incision line. You can see over there. Flip the muscle that side, and we move forward like that. So anterior component separation is like this, posterior component separation is like this, and posterior component is something which you call the net is there available in the net, you can see. So lastly bit is how a hernia enlarges. So this is about the ventral hernia, how it gradually enlarges. This is something question which is not taught, but I'll tell you a little bit of the physics of it so that you understand, you can see it in the exam. See, sir, you can say that, sir, the linea alba is destroyed by the midline hernia. So linea alba is very, very important. So that's why the lines of the abdomen is important. Abdominal wall muscle retract laterally. It's called unloading of the abdomen, right? Once the linea alba is destroyed, now hernia enlarges. So how does it happen? So that is the hernia. It's in midline, and once the hernia, as soon as the hernia is formed, the abdominal wall retracts laterally on all sides. Okay. And then the hernia, which was small, it becomes big, right? So what are the anatomical disruptions which leads to pathological changes, which leads to physiological changes? So first, since the muscle retracts laterally, there's a disused atrophy muscle. Okay, once the hernia component is there, abnormal, your muscle doesn't really work. So disused atrophy of muscle happens, muscle fibrosis happens, and the loss of elasticity is lost, which causes intra-abdominal viscera to come out. Okay, once it is out, the intra-abdominal viscera is out. Suddenly there's a decrease in intra-abdominal pressure, which causes the diaphragm to descend, and there's a response. The diaphragm descends, there's respiratory dysfunction. This is called the portal venous pressure falls, and intestinal mesenteric ischemia happens. Okay, because there's a decrease in intra-abdominal pressure, so the portal venous pressure falls, and this causes the intestinal and mesenteric ischemia, which reflexively leads to whatever is outside the abdomen, difficulty in reducing herniated intestine and mesentery further. So whatever is there outside the abdomen, that that becomes very edematous and very difficult for them to go back to the abdomen. And that actually causes what we know as the loss of domain. You've seen this term before used, the loss of domain. That's been defined by what? The loss of abdominal pelvic compartment volume and the necessity for abdominal viscera to reside with the arterial sac. That's called the definition of the loss of domain. Measured by the Tanaka index, which is the formula of an ellipsoid. The abdominal cavity, this is the main abdominal cavity you can see over here. This is the main abdominal cavity. And this is a hernia cavity. So abdominal cavity volume, which is 0.52 to A and B and C. A and B and C is what? Length, breadth, and depth. Okay. And the hernia sac value, 0.52 into ABC. 0.52 is the ellipsoid constant. Okay. The volume ratio is mentioned as the HSV, that is the hernia sac value upon the abdominal cavity volume. So Tanaka index is the formula of the ellipsoid, which is actually a volume ratio, in which the numerator is the hernia sac value, which is measured as A above the abdominal compartment. Okay, there's another method called the Sabak method also. So that's what you know as volumetry. The Tanaka index is HCV on HCV. So if it is like 80% volume or 20% volume is like that, this is 0.25. Sabak method is just HSV by HSV plus ACV. In this condition is 0.2% or 20%. Okay. So this is enough to know what is Tanaka index. So once there is if the abdomen is huge, if the hernia sac volume is huge, and you have more than 0.20, 0.25 Tanaka index is there, or more than 0.2 thing is there, how do you reduce, or how do you prepare the patient for it to reduce the hernia sac contents inside the abdomen? Because if you don't do this and you reduce forcibly inside, the person might land up off the hernia repair with an abdominal compartment syndrome. Okay, you want to avoid that. So you have to prepare the patient. So one of the techniques of preparing the patient is doing a progressive pneumoperitoneum, in which you can see that this is the hernia and then put a catheter. So this is just a CT scan that taken from these papers. So what happens is there's a loss of domain, right? In which the volume ratio is more than 20%, Tanaka index. Catheter implanted into the peritoneal cavity under anesthesia by injecting room air daily for 10 to 15 days. So this is catheter implanted over here, okay? And then you inject room air daily for 10 to 15 days. So entire thing is to basically volume air injected maximum is 2 liters of air pressure per session, or until the patient develops an abdominal pain, shoulder pain, or dyspnea is the end point. And then schedule for surgery after performing a CT abdomen and pelvis, which confirms the abdominal cavity expansion and reduction of volume ratio to below 20%. Okay. How does the volume ratio increase? Well, it increases by diaphragm goes up, diaphragm descends otherwise. Okay, and the entire anterior posterior and the height of the abdomen increases. Okay, and after you give respiratory therapy, you take the patient up for surgery. Okay, there's another technique which is called the chemical component separation with the botulinum toxin injection. Okay, in which there's 3 points on all the 3 sides, in which you put botulinum toxin injection at 200 units at 2 units per milliliter. It causes a flaccid muscular paralysis. Okay, within 2 days, and it stays for 6 to 9 months. This reduces the muscle thickness and increases the length of the muscles, which causes the easier to, once length of muscle increases, causes the hernia defect to come closer. Hernia reduction allows the closure without tension. So this chemical component separation also is a type of component separation. There's nothing connected to the Tanaka index. Tanaka index is only probably the new operator. This is basically a part of the component separation which we used anterior posterior. Okay. In anterior posterior component separation, we cut the extra nucleus, cut different parts of muscle to approximate. In which in this one, what they do is that for the chemical component separation, they just inject a botulinum toxin which causes flaccid paralysis, and when a muscle becomes flaccidly paralyzed, it increases in length, and that causes the tissue approximation in the midline. Right? That's a hernia recurrence. Lastly, what is an ideal mesh? Ideal mesh again is a theory question. Easy to handle, can be cut in shapes, flexible, rapidly incorporated in sutures, inert, non-carcinogenic, non-allergenic, cheap. Why do you need a mesh? Because wounds never really reach back to 100% of pre-traumatic state. The abdominal wall physics allow the law of lapses, hence there will always be more pressure to the weakest part, even if it's less bit weak, and therefore we can give the patient the best chance to not have recurrence. The mesh is not the treatment. The treatment is tissue approximation, the closure of the defect. Mesh you put for avoidance of recurrence. Okay. Last bit is that you must always mention that if this is the defect, you have to put a mesh which covers 5 centimeters of the defect from all sides. Okay. So if the defect is say, if it's a 5 centimeter mesh, 5 centimeter defect, how big a mesh you need? You need at least 5 centimeters this side, 5 centimeters this side. So if the 5 centimeter defect, you need a 15 by 15 mesh. Okay, isn't it? Minimum. 15 by 15 mesh minimum. Okay. If it's a 10 centimeter defect, 5 centimeter this side, 5 centimeter this side, 5 centimeter this side, 5 centimeter this side. So you will require 10 plus 5 plus 5, 20 centimeters, 10 plus 5 plus 5 by 20 centimeter minimum. Okay, say minimum. So I told you about internal IPOM and except this I've already mentioned. Last bit is what is a complex ventral hernia? Any complex ventral hernia is defined as when it has gastrointestinal, biliary or genitourinary compromised fields, when the leak is there, when there's an intracutaneous or what you call an intraatmospheric fistula, when there's the infected prostatic mesh is there, when hernia defects larger than 10 centimeters on any dimension with loss of domain, okay, Tanaka index, telecom, and any recurrent hernia is known as complex ventral hernia. This is actually a question that is asked in the examination. What do you mean by complex ventral hernia? You will say these 5 points. Right? There's a very important thing, which is sometimes, people ask, when should we put a mesh in infected field and when should we not? So according to the ventral hernia working group in 2010, if you mention this name, if it's a low grade risk with low risk of complication, no risk of wound infection, you can put a mesh. Comorbid, when the patient is smoker, obese, diabetic, immunosuppressed or COPD, okay, you put a mesh. But when there's a potentially contaminated previous wound infection, stoma present, violation of gastrointestinal, any leak has happened, any injury has happened, you do not put a mesh. Wait for infected, when you're itself including an infected mesh or there's a septic diasis, you do not push a mesh. Grade 1, grade 2, you can put a mesh. Post-op complications, wound complications, SI, infected complications, seroma, hematoma, skin flap necrosis, pulmonary complication, GI complication, abdominal compartment syndrome. Now, this, just like that has guidelines, these are SAGES guidelines. You know what SAGES are. The laparoscopic ventral hernia repair has a lower rate of wound infection than compared to open repair, established high quality evidence, strong documentation. Prior hernia repairs, large defect sizes, incarcerated hydrines increase the difficulty and duration of the procedure and should be taken into consideration by surgeons. So if there's a prior hernia repair, you're doing a redo hernia with a large defect sizes or an incarcerated hernia, do not venture into laparoscopic, you go for open repairs. Okay? Depending on the surgeon. Special situations as loss of domain, presence of abdominal skin grafts or an active intracranial fistula, the need to remove the previously placed prosthetic mesh or large abdominal defects may present contraindication to laparoscopic repair. So this is absolute contraindication for laparoscopic repair. Okay. So this is something you should know. Regarding the previous one, the prior hernia repair, large defect size, incarcerated hernia, depends on the surgeon what they want to do. Okay, so if it's a straight cut hernia without any of these things, laparoscopic repair is the best. Whether it has a prior hernia repair, large defect size, incarcerate hernia, it depends on the surgeon concerned, what he wants to do. But if it is a loss of domain, presence of abnormal skin grafts and active interconnect fistula is there, laparoscopic repair is strongly not required, but not indicated. Stages guidelines: while most ventral hernia is easily diagnosed based on the clinical examination, a preoperative abdominal CT scan or ultrasound may be considered for select patients with suspected ventral hernias to confirm the diagnosis or to aid the incision surgeon with a preoperative planning. Okay, in this case, in which whenever I see there's any kind of ventral hernia, I normally do a CT scan, right? Especially when there's an incisional hernia, you definitely have to do a CT scan. Placement of urinary bladder during laparoscopic ventral hernia repair should be determined based on the anticipated duration of the procedure and the location of the hernias. Okay, if the hernia is in the lower part of the abdomen, M4 and M5, okay, you place the urinary bladder catheter. If you think that you require more than an hour or maybe 2 hours surgery, then you put a urinary bladder catheter. Mechanical bowel preparation prior to laparoscopic repair may be useful to select cases, but additional evidence is on risk and benefits needed before a recommendation can be provided. Normally, some people they say that mechanical bowel preparation because they say that when we do an intraperitoneal repair, it makes the intestine collapsed. That's why they use it. Okay, but there's no quality evidence for that. Closure of hernia defect should be undertaken at the surgeon's discretion, DAP IPOM plus, as that theoretical advantage exists but not have been proven definitely by good quality comparative study. So there needs to be more evidence between DAP versus DAP IPOM plus. The prosthetic used during LVHR should be designed to bridge a defect in the abdominal wall size with appropriate overlap of sizes. I said 5 centimeters overlap on all sides. These are strong evidence. Okay. Asymptomatic seromas should be observed. Persistent symptomatic seromas may be aspirated under sterile conditions with low risk of complications. Recurrent seromas after aspiration that are symptomatic should be treated with surgical drainage and excision of seroma lining if possible. Okay. Laparoscopic repair of hernia with permanent synthetic mesh immediately following an enterotomy should be carefully considered in light of positive evidence and potential for infectious complication. Okay, so whenever you've done enterotomy, do not, if there's spillage of enteric contents, you have basically dirtied the site, it will become a dirty wound, dirty operation. You change the laparoscopic repair into an open repair if you need to do it, or you abandon the procedure and you deal with the enterotomy first. A tailored approach maybe include open and laparoscopic technique that should be based upon the operative findings, degree of contamination, surgeon experience, and patient interests. The possibility of enterotomy in management options should be discussed with the patient preoperatively. So to try whenever you're going for an IPOM repair or any repair, you have to say that this kind of conditions can happen in which I have to abandon the procedure, maybe do it the next time. Patient with delayed intestinal injury. What is delayed intestinal injury? Delayed intestinal injury, it means that you have done the IPOM, okay, and you have not detected any kind of enterotomy there, but you have done sometime. And that presents after you have closed the abdomen and present in the post-operative period. Patient with delayed intestinal injury following laparoscopic hernia repair should be taken to the operating room for bowel repair, resection, or GI tract diversion. Consideration should be given to mesh removal at the time of operation. So this is the condition in which you have done the IPOM, but later your resident gives you a call saying, sir, you develop some kind of a abdominal distension and all these things have happened. And what should I do? You have to immediately go back to the theater. You have to see what is, do a thorough diagnostic laparoscopy. You have to do an intestinal walk. You have to find out whether anything has happened or not. And if you find anything, you have to think that, yes, I not only have to repair that thing, any injury that I've caused, but also I have to remove the mesh. Why? Because ultimately the mesh is going to get infected. Okay, according to the grade, and only grade 4 5, it has become dirty. Infected prosthetic mesh salvage may be successful with a combination of antibiotic, percutaneous drainage, and wound debridement with negative pressure wound therapy. Now, there's a condition in which the patient has come with maybe 3-4 months later with a fistula or something like that. You've done a CT scan, MRI, and you find that there's some kind of a infection over that happening. It can be successful. You can give antibiotic. You can do a percutaneous drainage of any kind of liquid over there with a wound debridement or negative pressure wound therapy. Okay, you can do a trial of this, but when this approach fails, or definitely you don't do this trial in septic patients, mesh excision should be added. Now, physics of mesh. Now, the abdominal wall has normal strength of 16 N per centimeter. The mean elasticity of the wall of the male and female are different. Are the same. 16 is found to be around 23 in the vertical direction, 15 in the horizontal direction. So the strength is different in different directions. Normal pressure inside the abdomen is 2 to 20 millimeter of mercury. You know this. And when you do a vomiting coughing, this 2 to 20 becomes what? 250. Okay. That causes any weakness of the abdomen to open. That's why you have burst abdomen at that time. To handle such high pressure, the abdomen increases strength from 16 to 27. Hence, the mesh needs to be given strength of more than 27. So any mesh that we give has to have physics of more. So we can have propylene mesh to polyester mesh and expanded polyethylene mesh. Okay, propylene mesh. The thing is that it's almost like steel, but it causes intense tissue reactions. It causes pain and adhesions. Also, it shrinks by 30 to 50%. So that 5 centimeter overlap, whatever you put now, there's some kind of mesh shrinkage happens. So you have to take account of that. That's why you put 5 centimeters overlap on sides. Polyesters have improved conformity and tissue ingrowth with abdominal wall and all the characteristics similar to polypropylene. Expanded EPTFE is smaller pore size compared to PP with one side large pores and other side smaller pore size. At this point of industrial addition, it also does not facilitate tissue ingrowth in the abdominal wall, resulting eventually in encapsulation. The weaker hernias require also always require additional fixation. So EPTFE is a thing which had come and was used extensively, but then it has some issues. Synthetic or partially absorbable, which is what the purpose of constructing partially absorbable mesh is to mainly to reduce the density of the biomaterial and its subsequent inflammatory reaction while maintaining the intraoperative handling characteristics and long-term wound strength. So there are two types, polyglactin 10, 910 and polyglactin 25. Now what about the non-absorbable synthetic with barrier, which is called a composite mesh, in which you have to this mesh is attached to the not only the underside, the peritoneum, but also to the it can contact with the abdominal organs, especially the intestines. So this is what this basically you used EPTFE, polyurethane, oxygen cellulose, omega-3 fatty acids, collagen or beta glucan, and you combine it with polypropylene, polyester, and EPTFE on the upper side, to the peritoneum side. Okay, and then this is what is used in the interperitoneal mesh treatment in IPOM. We use a composite mesh. What is a biological mesh? Biological mesh is, and the composite mesh is very, very expensive. The biological mesh is what a primary importance of construction of biological mesh is to overcome the problems of synthetic mesh and provide mechanical support, tissue remodeling, along with mesh scaffold in order to create a highly organized collagen network and thereby to establish a new vascular access to the hernia site. Main disadvantage is that the connective tissue formed at this site is only 70 to 80% strong. Okay, this is not that strong, and there might be a transmission of virus in many biological products. How to choose a mesh? In inguinal hernia, non-absorbable, inguinal hernia I'm talking about, right? You use a polypropylene mesh, okay, non-absorbable synthetic, it is 8 to 12 centimeter at least, because you'll have to cover the myopectoral orifice or orifice of Crusoe, 5 centimeters on all sides, okay. Ventral hernia is what? In ventral hernia, for extraperitoneal repair, I do a polypropylene mesh, same as the inguinal hernia, that's why it is cheap. For interperitoneal, I use a composite, that's why it is expensive, because the bilayer, you put cellular and all these things. And both should be 4 to 5 centimeters from the measured defect border. Okay. Now, there's something which is thing. In polypropylene, there's a moldex and proline, whatever you use over here, is there in all books. We'll just go with this. There's a polyester, which is Paratix composite, which we use in IPOM. Okay. Right. Characteristics of mesh results big from mesh is the ideal durable tissue tolerance. This you should find from all books, so it's not a problem. Okay. Thank you very much. This is actually a very important topic. And I've tried to address the points which are actually asked when you do a very good examination. And hopefully you will do some more readings regarding the various topics that I have touched. And that, tried my best to finish the entire whatever is asked in the hernia examination, even in a super specialized level. Okay, thank you very much.
very good day and a very good evening. We will start by discussing on a case discussion on a renal lump and what are the differential diagnosis of a renal lump and what are the technical questions that you should be asked when you are getting to get a case of a renal lump. Now, ladies and gentlemen, as to start with, out of all the lumps in the abdomen, when you talk about a patient with a renal lump is always a swelling on the flank, which will lead to, if you think over of this patient and this being the rib cage and this being the iliac spine, this area will have an obvious bulge, which is the flank, and one of the causes of an asymmetric bulge is always an enlargement of the kidney. Now, definitely when you talk about an enlargement of the kidney, out of the differential diagnosis that we will make in this area now is always to talk about retroperitoneal tumors or retroperitoneal sarcoma to be more particular, and there will be some rare causes of other parietal swellings which are extremely uncommon to be obtained in this area. So the basic bottom line again is that if you have an asymmetric bulge of the flank, like the picture that you get to see in this one, this is going to produce an enlargement or will be due to an enlargement of the kidney, retroperitoneal sarcoma, and or is a parietal swelling. Now, what are the signs that we observe in a patient with a renal lump? Now, when I talk about the signs of a renal lump, now signs means something that we as physicians do elicit. That means the point number one is there is a flank that is bulged and there is an asymmetry in the abdomen due to the bulge in the flank. The second point is the renal angle is obliterated, which technically means that if this is the spine and this is the back and this is the 12th rib, it is this angle called as the renal angle which is obliterated, meaning that the normal flat appearance is lost to give a bulge in the area. Okay, now this is not obviously very well appreciated sign, particularly in an obese, but if it is appreciated, this should be always considered to be probably due to a kidney pathology. The number 3 sign that we always must understand is on palpation, a renal lump is either bimanually palpable or is bilautable. Now, what do I mean by this? Now, the term bimanually palpable will obviously mean that the lump is so big that both the hands are able to palpate the lump at one point of time. So this kind of a lump that gets palpable is called as a bimanual palpable lump, and kindly remember is not only a characteristic of a kidney swelling but can also be due to a retroperitoneal sarcoma. Now, the another method of palpation, we are coming to the movement with respiration quickly. Another method of palpation will be then something called as ballotability. Just give me a minute, please. Something called as ballotability. Now, it is good to observe this picture now, what I am trying to do. What I have tried to do is that by the lower hand which palpates the lump, what I have done is I have given it a gentle push, and now the upper hand can feel the lump. Again, I give a gentle push, it comes down to the lower hand. Again, I give a push, so it looks like a volleyball competition, is not. But remember that if this thing happens, this maneuver that I have shown in front of your screens is technically called as a ballotability and will require the presence of 2 modalities. Not only will you require a long pedicle, that means an artery and a vein, but you will also require, on the other hand, a heavy lump which can move up and down like a heavy ball rather than maybe a ping pong ball. So palatability is a test that you require two hands. The lower hand feels the lump, pushes the lump off, and then it comes down. That is, ladies and gentlemen, called as palatability. Please understand that either the lump is bimanually palpable or ballotable. You can't have both together. So this is what is important in the renal palpation. There could be some other subtle signs like that called as for tenderness, etc. So this is the first and the most important thing, and the final thing that we will talk before we talk the differentials is the movement with respiration. Now remember that a renal lump will usually move with respiration, given that it is related to the diaphragm and it is related to the spleen. But what is more important is, when does a renal lump stop moving? The answer for this is very simple. When will it stop moving means the tumor is so large that it has infiltrated the surrounding structures, maybe from the diaphragm, and thus it becomes technically impossible for the movement to occur because it is fixed. This is or the renal lump is such large a renal lump that it is impossible to be pushed. So please remember this part, that there is something called movement with respiration, bimanual or ballotable, renal angle obliterated, and a flank which bulges asymmetrically are the characteristics that we have known, ladies and gentlemen, of a renal lump. Now, how do you make a difference between a renal lump? Now, the first point obviously is something that we talk about, a renal cell cancer. The typical profile of a renal cell cancer is an age between 60 years on an average. The next one will be the patient has a long history of smoking. And the third point is, this patient typically presents with a painless hematuria, sometimes with passage even of clots, suggesting that the bleeding can have been profuse. It is this group of patients that can present with a lot of paraneoplastic syndrome, and hence it is always a good attempt to talk to the patient, ask about and write a negative history on a paraneoplastic syndromes. Okay. Now, after we have talked about what is exactly a renal cell cancer, on palpation, as I have said, either you get a bimanually palpable or you get a ballotable lump. Okay, so this is the first one, and as I have said, anyone more than the age of 60 who presents with a hematuria is a very, very serious sign. Please remember, these are the points that goes in favor of a renal cell malignancy. Okay, now renal cell cancers are the commoner ones and hence a point of discussion. But if you get a patient with a hydronephrosis on one side, then what is your opinion on a hydronephrosis? Now, vis-a-vis renal cell cancer, hydronephrosis, remember the kidney is usually firm in consistency. Here the kidney can be hard in consistency. Point number one is firm. The point number two is the surface is absolutely smooth, maybe with a lobulation, but that is something that is not of our headache. So it is, remember, the surface is smooth with a fine lobulated appearance. So please remember, the surface is smooth, there are lobulated appearance, suggesting that there are bulges about. So this is what is important in that. So either you have a hydronephrotic kidney or you have a cancer of the kidney. So please remember, these are the two things. Rarely you will get not only one but a bilateral disease in which the kidneys are studded by cyst-like structures, and either one of them will be palpable. Usually both are palpable together. And what is important is this is called as an adult polycystic kidney disease. And remember that in this group of patients, the presentation may have been due to a CRF, or the patient underwent surveillance, but by the time the patient came to you, well, it's a very heavy kidney, So please remember that hence a lump is usually a heavy lump that is palpated in any of the lumbar regions of the abdomen. So ladies and gentlemen, this is a very brief introduction to the differential diagnosis of a renal lump, where we have talked about malignancies, which are the most common causes, followed by hydronephrosis and followed by other theoretical things. So this is a very straightforward case. Always be open to discussions. Like in a case of a renal cell cancer, what is the type of biopsy that you will like? Why don't you do an FNAC? What is the role of staging investigations like a staging CT? What are the various stages of renal cell cancer, etc.? So what is important is, please understand that when you get a renal lump, it is all about narrowing your thoughts to a couple of them. Please remember, hydronephrotic kidney is not soft. Always remember that. Okay, so with this, we end this first discussion on something called as the renal lump and the various differential diagnosis. A very good day. This brief discussion today is on a very common case that you are expected to get in an exit examination, that is on something called as cancer of the penis. Now, this class is a recapitulation of the basic facts, particularly detailed clinical management of the neck, groin lymph nodes. So what I will like to discuss about is what are the important features that a surgical postgraduate is required to know. Now, whenever we talk about a patient with a cancer penis, now there are a few fundamental things to understand so that you do not make some straightforward mistakes. Number one is that when you are taking the history, now in the history, what is important is there are two groups of causes that we are required to know. A first group of causes are something called as predisposing, and the other group of causes are something that is called as pre-malignant. So there is a difference between this, and majority of the books have not made the differences or have not been very clear with the differences. What I have tried to do is that with the latest NCCN and Campbell's Urology as my two cornerstones in the management, when I get a patient or someone is asking me what are the known etiologies for a cancer of the patient, for a cancer of the penis, or why did this gentleman ask about, or what are the histories that you have taken from the gentleman, please remember that the predisposing causes are balanitis, whose history is elicited by repeated episodes of burning sensation in the urine along with the ballooning of the prepuce. So please remember, that is a typical presentation of a phimosis, ballooning of prepuce along with a burning sensation in the urine, suggestive of an UTI. Now, a history of tobacco use is very important. So remember that, as I have said, you are required to ask the patient how long or what pack years has he smoked. Now, talking about HPVs and HIVs are important, extremely important factor. And then you are required to take the social history of the patient, addiction history of the patient, any form of any high risk exposure that the patient may have had as an part of an other etiologies that could have been responsible for a penile malignancy. Now, in this, what is interesting is in the last couple of years, the human papilloma viruses have been strongly implicated into the cause, in which, as you can see, there are 3 strains. Now, what is important is this group of viruses, and then you are required to know other counterpart diseases that this group of viruses can do. So this is the first important major part on the part of a clinician to understand. HPV related other cancers should be mentioned, that makes the examiner very happy. The last part is the presence of a genital wart is important, and your requirement is to ask about the high risk exposure of the patient and any changes that the patient could have had. Now, when you talk about pre-malignant causes, because examiners love to ask you this, we have either a Buschke-Lowenstein tumor or you have something called as a Bowen's disease, etc. So these are all theoretical issues, but more important is predisposing versus pre-malignant. Now, when I talk about this predisposing and when I talk about the other causes, majority of the patients, remember in an examination, do present with either a fungated mass or an ulcer. That is false smelling. That is something that I will not talk. What is something of interest in my topic is, when you get a patient with a penile ulcer, only at that instance, try to describe it as a penile ulcer. It becomes much easier for you. Now, when you talk about a fungated growth, now this appears to be a large proliferative growth. So please know your languages very properly. Sorry, this is to be described as a proliferative growth. Okay, and this proliferative growth is a better word for this patient. Okay, whereas on the other end, if you get an ulcer, as you know, the ulcer has an edge, ulcer has a floor, ulcer has a margin, etc. So what is important is understand how did the pathology start. A group of patients will come with a group of patients are going to come, remember, who have a repeated episode of a foul smelling discharge from the penis, and this is coupled with something called as a recent onset phimosis in a patient who did not have phimosis before. So please remember that these things are to be a part of the history and these things are to be a part of the description of the patient. Okay, so this is the first part on cancer of the penis. Now, the next part is what are the complications that the patient may land up with. So the complications definitely of mentioning are, what is mentioning are that the reconstruction of the urethra, remember that, and the important part about the infiltration of the urethra, not the reconstruction, sorry, are again a very late stage of the disease. So what is important is you are required to know retention of the urine, or replacement, sorry, retention of the urine is a late feature. So this is all the things. So the history points of interest will include the onset of a recent onset phimosis, or an ulcer or a nodule, and how did this ulcer and nodule proliferate as a part of the description. You should also remember in the patient with a cancer penis history, the major part of history includes predisposing and pre-malignant causes, and you are required to search out what is the etiology that may have been responsible for a cancer of the penis. Particularly human papillomaviruses have been started to be implicated. So this is the first part of the story on this. Now, how to treat this? As I have said, the first part of the story is to make a clinical diagnosis, as you would be doing in an examination, and then followed by assessment of complications of an cancer of the penis, particularly in interest to a local lymph node involvement. Remember that now, if you talk about local lymph nodes which are not only enlarged, but also there are chances of infection, abscess, matting of nodes, ulcerated nodes, and an erosion of the artery. So please remember these are pretty serious. You can ask about whether do you have any lump in the groin. The answer may not be a yes. Whereas on the other hand, the patient may have had a very serious complication because of this. And hence it is important point to understand that in the lymph nodes, here are the first group of the things that are needed to be said. Now, when I talk about the lymph nodes and talk about pelvic lymph nodes, remember that for the history, remember that for the information gathering, always think about a lymphedema of the limb. Always think about lymphedema of the limb. Whether that is a potential for happening or what is other again. So please remember that there can be some other modalities, but what is important is local and pelvic is an important thing to remember. Now, some examiners can ask you about a differential diagnosis of a penile ulcer. What is important is something that you should always talk about is a syphilitic ulcer, which are a painless ulcer, painless with multiple bilateral nodes rather than unilateral nodes. And all the things that you can get to see is the floor is technically made by something. And please remember that this is one of the strong differential diagnosis that you are required to know. Okay. Now, beyond this, the last part of this discussion is what is the plan of the treatment, ladies and gentlemen. Now, till now, I have talked about cancer penis, predisposing causes, etc. I have not talked the TNM for one purpose because you are required to know the TNM for the rest of the topic. Now, when I talk about a cancer of the penis with or without lymph nodes, as you have said. So, the first point will be when you talk about managing cancer penis with this is you confirm the diagnosis that this is a cancer at all. If it is a cancer, then talk about staging and support. The third part of this is after you have done your radiology, etc., it is good now to form an MDT, multidisciplinary team. Okay, and that multidisciplinary team determines the curative options, etc., and thereafter follows. So please remember, any malignancy 1, 2, 3, 4, 5 confirm the disease, stage and support, MDT discussion, curative options, and follow up. Okay, so this is the first plan. Now, how to confirm that this is a cancer? So that thing is very standardized now. We like to take an incisional biopsy or a punch biopsy, whatever you like to call this to be, with the depth being at least the subcutaneous tissues or the lamina propria. Okay. Now, the next part is when the pathologist will give you a report that this is a squamous cell carcinoma, remember that the pathologist is to be requested that please mark what is the grade, because the grade that you are going to give is going to change the life of the patient. So that is so important. Right. Now, after I have talked about this part, then the second part of the story remains. The second part of the story then. So the first part of the story is to know about the confirmation. The next part is now stage and support. Okay. Now the next part of this is a stage and support, which technically will mean that now after your diagnosis is confirmed, then you are required, after the diagnosis, remember, is confirmed, you record to stage, and out of them, MRI of the reliable stage. But before that, it is always important to tell the examiner, I have seen by clinical palpation of the stage, which is not an accurate stage. Okay, but what is important is, it is not, now, what is important is that in a case of a cancer of the penis, the first part of the clinical staging is something that you can do, like you can palpate the shaft and the extent of the movement of the shaft. Okay, now, as I have said, what is important is, examiners can ask you about how many nodes, or not only the nodal anatomy, but what are the maneuvers to find the node. So please remember this thing, that in non-obese and in obese, what are the things to be done? That includes, remember, in a non-obese clinical examination with ultrasound. In an obese, remember, things will get a bit different, is that in an obese, you are required to clinically see the patient and find out if there are involvement or not. Okay, now the next part of this is that what is the surgery or treatment plan? We have discussed it in an MDT. MDT says that, okay, doc, go on with the surgery. What is the surgery? Now, in an DNB or an MS examination, I would have always preferred penile amputation. Now, you can write this for a part of a theory. I understand that. But when you talk about a part of a theory, this is what exactly is important. Then, what is important in this one is, so when you talk about the primary, the nature of the surgery is going to be totally dependent upon organ preservation or an organ amputation. If you're thinking organ preservation, which is something that you should not say in a viva voce examination until and unless you are asked for, I will concentrate just most on a partial, a total, and a radical penectomy. Please remember that one. Now, what is a partial? The partial penectomy technically means that one part is out, so the rest of the part is there. That is called as partial. Okay. Now, what is now total? Total means very simply, you cut off the penile corpora cavernosa at the level of symphysis pubis. So that is called as a total. And when you talk about a radical, now a radical will mean you go into the pubic rami. There are the two bulbs that are written, and this. So that is the radical. So please remember, the surgery for a penile is either an organ preservation, that is for theory, or you have a penile amputation. Now, theory question again, I am not interested with that. There is an operation called as glancectomy. Okay, so please remember this part, that these are the various surgeries that you can think of. Now, after you have done with the surgery, remember the stump business is an important one, and hence I always draw this picture to make everyone understand. Say for example, the yellow dot is an ulcer, and you are required to take a 2 centimeter margin, and then you are required to do what is done. So please remember that this is what exactly. No. So this is what you have to have a very clear what is going on. Okay, the final part is what is there after we have talked about local. Now let's dedicate the next 10 minutes to products. In a penile cancer, the controversial probability is still prominent. Now what is important is, number one, you need to divide the cancer into a grade 1 and a grade 2. Now, what is important is these parts. If the staging that you did by clinically palpation and doing an MRI if possible, what is important is, now understand the point. Now, in this, now what is very important is, now see, if this is a low risk disease with an early non-invasive variety of the disease, like the one that you can see in your picture. Okay. Now this is followed by, now, so please remember that this is the group with a low risk. So in this group, you can do a very basic thing. Is that, just a minute, just allow me. In this group of patients, what happens is that majority of these patients are evaluated for a palpable versus non-palpable. If it is palpable, then if it is a T1S TA, if it is given with a 4 weeks of antibiotic, even if it persists, describe a 4 week of an antibiotic, then you do an FNAC, and if the FNAC comes to be positive for a cancer, you are going to go do an ileoinguinal node dissection. So this is the first part of the thing that I require you to remember. So please remember this part. Okay. Now, after this, we have seen on the other side, what if the grade is now coming to higher and the tumor is a large one now? In this cases, as you can see in the picture, what is seen is that after doing, now what is important in this perspective is only one, is that if it is a T1 stage, that means the depth of the infiltration will be much more and the nodes are palpable. Okay. Then remember, it is better to do an FNAC still, and then followed by using the ileoinguinal node dissection route. If the FNAC comes to be negative, go for a 4 weeks of antibiotics, then go for a surgery. So please remember that what is important here is what are the various types and what is the algorithm that they will follow. If the stage of the disease is much more advanced, which means a T2, T3, T4 lesion, then they have a chance of a mobile involvement in this at the mobile producing problems. If it is a bilateral negative Now, what is important is that if there is a bilateral negative, then that means the lymph nodes are not palpable. Please understand this word. Okay, and if lymph nodes are not palpable, again, so remember that the only thing that you can do is either you can do a lymph node biopsy, sentinel lymph node biopsy. Sorry, I should have said the word sentinel lymph node biopsy, and or you can do a superficial inguinal block dissection. That's it. Okay, so please remember this part. Whereas on the other hand, if it is a unilateral palpable less than 4 centimeter mobile lump, okay. Now, what is important in this description is only one. If it is unilateral palpable less than 4, then please remember you are required to be given then more or less with a dynamic sentinel lymph node biopsy. If the dynamic sentinel lymph node biopsy comes positive, you go for surgery. Now, this is very easy to understand. The problem is with this group, which has this G1, G2, etc. But this is more or less a good, again, understanding that if it is unilateral palpable, then you are going to take this down. Okay. The next part of the thing is something called bilateral greater than this. Now, what is important is what are the important remember. Okay. Now, what are the important points to remember is that in a patient with a cancer penis, both nodes are negative. You can go and still with an antibiotic for 4 weeks, and then one side of the patient, remember that as an important tool. One side is positive for a cancer, then what are we going to do? And what will be the status of the other groin? What is important is that if this happens, then then the more important point is how are you going to change? Like this thought process that I have made you inculcate today is a pure derivative from Campbell's urology. So what is important is that I hope that all of you will be reading bilateral and you will be reading neoadjuvant. Okay, so this is how we manage a patient with a cancer penis. The basic crux of the story is that you are not going to take any names, and number two is that it is what is important to understand is that in a cancer penis the main controversy lies with the lymph node. So please make sure that the lymph node assessment is understood by all. So I think this is a straightforward case with the penile cancer, and I will like to encourage you.